All right, welcome. This meeting's called to order. This is our second July board meeting of the season. Our meetings are going to continue to be hybrid. Healthcare Authority staff will be on site when possible, and board members and other attendees have the option of attending on site or via Zoom. For our members of the public attending via Zoom, our opening slide is information about attendees. You can turn on closed captioning subtitles. Also, public meeting attendees will be able to activate their audio and video during designated public comment periods, and we'll control that from the room here. For board members attending in person, please remember to turn on your microphone so that we can record your comments. Let's go ahead and do roll call. Harry.
Yes, I'm here.
Morning, sir. Kurt.
Morning.
Here. Morning. Tom.
Here.
Morning. Michaela.
Here.
Morning. Elliot.
Here.
Good morning. Sharon.
Present.
Good morning. John. Here. Good morning. And Michael Tunick from the AG's office.
Here.
And I'm Lou McDermott. I'm the COO here at the Healthcare Authority, and I'm filling in for Mary Ann Lindeblad as chair today. With board members attending both in person and virtually, it'd be helpful for board members to hold their question until the presentation's done or when the presenter pauses and asks for questions. Board members attending virtually will be watching for your Zoom hand. We have a few resolutions scheduled for action at today's meeting. The public is going to be able to provide comments specific to each resolution before the board votes. And the public's also going to be able to provide comment at the public comment period at the end of the meeting. At that time, public participants is going to need to raise their hand. We will go ahead and capture that, and we will call on you, and then we will activate your ability to be on audio and video. As a reminder, if the public has questions during a staff presentation, the presenter's contact information is included at the end of the presentation. Feel free to email them, and we'll see what we can do. Dave is going to prevent us. Dave, are you going to prevent us from having an agenda today? I hope not.
I'm not going to prevent you from having work today.
What's on the agenda for today, sir?
Good morning, Chair McDermott, members of the board. Today I present to you some things to do, including, I believe, 7 votes, 2 on minutes, 2 related to hearing aids, and 3 on non-Medicare / employee premiums for plan year 2026. In that order, and after we have all the voting action of the board addressed today, we will then, we are pivoting quickly internally to, I won't say we're pivoting to the start of open enrollment activities. Alyssa will say open enrollment for her started in February, March, but it's really a true pivot point after the board takes action. Because as a reminder, no plans exist for employees and non-Medicare retirees until you take action. The slate is completely blank as we sit here at 9:05 a.m. this morning. But after the board takes action and we actually have plans, then we can truly move into the final stages for open enrollment readiness. So Alyssa and Brett will be here to talk about our systems and the OE process. Then in response to some board questions from earlier this season, I know that today is going to have some challenging votes for folks, and that there's board members have expressed interest in understanding what it takes to expand the medical plan offerings within the portfolio. And so John Parton's going to walk through and describe kind of at a high level, kind of like what our procurement processes look like. And by high level, I really mean at the 5,000-foot level, because there's a lot of detail that he's going to go through about kind of what that looks like, the timing, what goes into that process, kind of from an academic perspective of what procurements look like. And then we'll finalize the board meeting schedule and be done for the day. So as a reminder, bathrooms are down the hall. When you look at the elevators, turn left. And if we have an emergency, we purposefully walk across the street into the visitor parking lot. And with that, I'm not going to prevent this meeting from proceeding any longer.
I'm going to hear about that the whole day. Any questions for Dave? All right. I think we're voting on some meeting minutes, and Elliot's correction is in there. All right. Voting on June 26, 2025 meeting minutes. Are there any comments from the board? Hearing none, do I have a motion to approve the minutes?
So moved.
Is there a second?
Second.
All in favor, say aye.
Aye. Aye.
June 26, 2025 minutes are approved as written. Were there any opposed? Forgot to ask that. I'm off to a little rough start this morning. I got a good night's sleep too. I don't know what's happening
the script.
here. I'm trying. I know. He's like, come on, man, just read. All right. We're going to vote on the July 10th, 2025 meeting minutes. Are there any comments from the board? Hearing none, do I have a motion to approve the minutes as written?
So move.
Is there a second? All in favor, say aye.
Aye. Aye.
Any opposed? What was that last comment?
That
Sharon?
was an aye. That was an aye.
That
Thank
was an
you.
aye. Okay, excellent. Hearing none, no opposed, July 10th, 2025 minutes are approved as written. Excellent. Ryan Ramsdell, come on up, sir. UMP team manager in the PEBB division is going to bring back a couple of resolutions for voting today regarding hearing instruments. After Ryan reviews the resolution with us, I'm going to ask for a motion to adopt. A second. We'll invite public comment on the resolution, ask for discussion from the board, and then we're ready to vote. We'll get going. Ryan's materials are behind tab number 4. Welcome, Ryan.
Good morning, Chair McDermott, members of the board. My name is Ryan Ramsdell. I am the UMP TPA team account manager. Going to cover hearing aids again today, and then there will be a couple items for action. So first off is some feedback and follow-up from the last meeting. We had some inquiries in regards to the hearing aid benefit. The first one was around Costco. There was a question as to whether or not Costco was in network for hearing aids, and verifying with our TPA, Costco is not in network. Out-of-network benefits would apply, meaning the same benefit with balanced billing and a likelihood that members would need to submit reimbursement. This is no different than what they currently do with any providers that are out of network. Any questions on that one?
Yes, I'm just curious why Costco, because as the feedback is out there that they are usually the best place to go in terms of cost. Why is Costco not in network? Isn't there a way to add them?
So as I've talked with people about Costco, everybody wants them to be in network, and they don't necessarily, you can't make anyone be in network, and there's a lot of interest from a lot of areas. I know that there have been attempts to, and just not an agreement. That doesn't mean that those conversations aren't ongoing. But it's not for want of, potential contracting efforts, but they are kind of like, as you said, there's a lot of desirability. They're desirable for a network standpoint. And so, it's, I can't remember in real estate if it's a buyer or seller's market that describes, but they kind of are in a strong position to decide where exactly they want to be. So we'll continue to work with regions to attempt that. But they are kind of desirable for everybody kind of desires them to be part of their network. And so they can be selective.
Okay.
But we will try. We will work with regions to keep trying.
Another item to address is circumstances when you have a higher cost medical device that's prescribed due to medical necessity. Typically, one of the aspects of this is Regents believes that most members will be able to obtain a hearing aid that will meet the medical needs through the established allowable amount. If they are unable, there are always aspects within the medical plan to pursue things such as medical appeals through the process for consideration of medical necessity for a higher cost hearing aid, assuming that it is not just for preferential reasons. And then I think because it has come up in other board meetings, just to clarify, cochlear implants, that's an aspect a lot of people try to associate with the hearing aid benefit. It is covered separately, similar to other medical services. I do have to call out there is an HTCC, which is the health technology, I can never remember, clinical committee that has some caveats, particularly on bilateral cochlear implants, but sort of a separate issue. Any questions on those topics?
So just to be very, cochlear implants are just a completely separate benefit part. And a little bit more on what HTCC is. It's a committee that was created by the legislature and run out of this agency that looks at the phrase is emerging technologies and makes decisions on behalf of state purchased healthcare as to what are the coverage parameters or limitations on various services, and the Uniform Medical Plan is required to implement HTCC decisions. The fully insured carriers are not subject to the HTCC decisions, but the Uniform Medical Plan is.
Just a quick question. Do we know how many people annually on average get cochlear implants?
I don't. We certainly could find out.
I'm just curious whether it's a popular treatment.
Sure.
Thanks.
All right, next slide. So I'm just going to reread the resolution from June 8th, 2023, and then hand it over to the board for action on two other resolutions. So as a reminder, as adopted on June 8th, 2023, Resolution PEB 2023-03 related to UMP hearing instruments. It was resolved that beginning January 1st, 2024, prescribed hearing instruments in all uniform medical plans plans will be covered up to $3,000 per year with hearing loss at least every 36 months without member cost share. Coverage for members enrolled in UMP Classic, UMP Select, and UMP Plus are not subject to the member meeting the plan deductible. And coverage for members enrolled in UMP Consumer Directed Health Plan are subject to the member meeting the plan deductible. Next slide. I'll turn it over.
One of the things I just wanted to remind the board of is that as we go through the process and we ask the board for, we ask the public for if anybody from the public wants to weigh in, and then if the board wants to weigh in. Sometimes in the past, and I've noticed we haven't done that much lately, but we did it at the SEB board, is that board members have feelings about the vote and they want to talk about it a little bit. And they're like, when is the best time to talk about it? Historically, people have talked about it as their vote comes. So if it's time for you to vote and you have a statement you want to make, you have some additional thoughts, you are pleased or displeased or whatever it is, that's an opportunity as well. So we don't have to whip through the voting. If you want to make a statement or say something, that's totally fine. And we had that come up at SEB. Some people wanted to talk about things and sort of explain their vote prior to their vote during the comment period. And it's like, no, you can, when it's your time to vote, you have the floor. You can say whatever you want, do whatever you want, as long as we get a vote at the end of it. That's fine. Yeah, right. So I just want to make sure people understood that, because I know there have been, it's been a difficult board season for a variety of reasons, and I'm sure people have some thoughts they want to share. So I want to make sure you're aware that you can do it during that time. All right, we're going to vote on Resolution PEB 2025-05, rescinding Resolution PEB 2023-03, UMP hearing instruments, resolved effective January 1st, 2026. Resolution PEB 2023-03 is adopted on June 8th, 2023 is rescinded. Is there a motion to adopt?
So move.
Is there a second?
Second.
Any comments from the public? Seeing none, any additional comments from the board? Hearing none, this will be a roll call vote, starting with Harry.
I vote yes.
Kurt,
Yes.
Tom,
Yes.
Michaela,
Yes.
Elliot,
Yes.
Sharon,
Yes.
and Lou, yes. Resolution 2025-05 passes. Thank you. Next, we're going to vote on Resolution PEB 2025-06, the UMP hearing instruments. Resolved that beginning January 1st, 2026, prescribed hearing instruments in all uniform medical plans will be covered at 100% of the allowed amount every 36 months. Coverage for members enrolled in UMP Classic Medicare with Part D, and UMP Select is not subject to the member meeting the plan deductible. Coverage for members enrolled in UMP Consumer Directed Health Plan is subject to the member meeting the plan deductible. Is there a motion to adopt?
So moved.
Is there a second?
Second.
Any comments from the public? Seeing none. Any comments from the board? This will be a roll call vote as well. Harry,
Yeah, I vote yes.
Kurt,
Yes.
Tom,
Yes.
Michaela,
Yes.
Elliot,
Yes.
Sharon,
Yes.
and Lou, yes. Resolution 2025-06 passes. Ryan, thank you.
I also, Chairman, want to thank Ryan and the various parts of our team that have been working on hearing instruments. And I think Ryan said this before, but I anticipate we're going to continue talking about them next board season. We learn something every year, and there's some nuance, and it keeps evolving, as Ryan said. But this isn't the last time on hearing aids. I think there'll be year 6 or 7 in a row that we'll talk about hearing aids. So just preparing everybody that I appreciate the support on this moving forward, but I think we'll have more to talk about next year.
We'll see you next year, Ryan. All right.
We'll hear him next year.
Yes. Plan year 2026 non-Medicare premiums. Tanya Dool, Herb Finance Manager in the Finance Services and Healthcare Purchasing Administration, is going to bring back the PEB program's plan year 2026 non-Medicare premium resolutions for voting today. After Tanya reviews each resolution, we're going to ask for a motion to adopt, a second, public comment on the resolution, discussion from the board, and then a vote. Materials behind tab number 5. Tanya, welcome. I'm kind of getting in the groove now. I think I'm feeling it.
We'll get warm because you have a few resolutions to read.
And we do have a few resolutions.
All right. Good morning, Chair, members of the board. For the record, my name is Tanya Duell. I am going to ask the board today to authorize the 2026 non-Medicare premiums. Last week, we had a pretty good lengthy conversation around the proposed premiums for 2026. I do not have all of those that we're going to walk through again today. They're in the appendix if anybody wants to, revisit anything, but we have just one slide for each, the employees and the non-Medicare retirees, to just glance over one more time before I turn it over to Chair McDermott to walk through the resolutions. So first up is the slide on employee premiums. This is, I think, my favorite view of the proposed premiums, which compares the current 2025 premiums to the proposed 2026. Again, these are sorted by carrier and plan. And then the single subscriber premium for 2026 as compared to the 2026 proposed rate. And then it shows the year-over-year comparison in terms of dollars and percentage. I also left the enrollment on this slide so you can see the percentage of enrollment by plan and carrier. Just noting there is no UMP plus on this slide. So when we walk through the resolution, the board authorizing each carrier resolution adopts the premiums and plan design for each of the carriers. And because there is no UMP plus premium here, the board is not authorizing any rates, so the plan will not exist. Can't exist anyways per legislation. So these are the employee single subscriber premiums. I'm happy to walk through anything else in the appendix. The next set of slides are the same kind of look, but at the non-Medicare retiree premiums. As a reminder, our non-Medicare retirees, these are retirees who are not yet eligible for Medicare. The board authorized the Medicare premiums at the last meeting. So these are the members who retire but not yet Medicare eligible. They pay the full bid rate plus a minor admin fee. So this is essentially almost the full bid rate. Tom.
Yeah, I'm just curious, how many members are in that non-Medicare retiree?
It's funny you asked that, Tom. I was looking at the slide this morning. I was like, hey, we didn't put enrollment on there. So the answer is for Kaiser Northwest, 77. For Kaiser Washington, as I'm doing it at the carrier level, not by plan. At the carrier level, Kaiser Washington, 1,214. And then for UMP, 5,838. So from top to bottom, 77, 1,214, and then 5,838 is the non-Medicare member enrollment. We will add that in the future on the slides, but I also noticed that, and so if you weren't going to ask, I was going to tell you it anyway.
Yeah, I know the answer to this, but I kind of feel sorry for these people that they're in that gap. They could be somebody that's worked 35, 38 years and they hit that point where they just, they can't do it anymore. It's a good thing that they retire, but they have 6, 7, 8 years before they are Medicare eligible, and it's a sock. And I suspect there is nothing that can be done for them. Is that
right? One of the things that is most critical in some people need to retire and or have a reason that they aren't able to continue working, and then there's the planning your retirement phase. That if you don't have circumstances that kind of force you to separate from the workforce, we know that insurance is one of the driving factors of when people retire. That's why we have such close collaborations with the Department of Retirement Systems to help people understand that. But you're right, Todd. Like it is a very tough spot until somebody reaches Medicare eligibility. And I will regularly hear from people that they were so happy to turn 65 because their premiums went down at the healthcare authority. And thank us for that. And I was like, well, it's actually a creature of insurance changing the day you turn 65 or the month that you turn 65. So there really isn't something structurally for us to do. But you're right. It's a really tough spot, and it drives, I think if healthcare cost in that intervening year, like that's one of the reasons people often have to factor in when they're retiring between 60 to 65, or depending on when they do meet full pension rules, depending on what plan they're in, as early as I think 57, 58. There's that range there, but a lot of people will say, I'm ready to retire, but for health insurance, and they are factoring in where they can where their projections are on affording non-Medicare premiums, or if they really do need to wait till 65. It's definitely a tight spot, but we do collaborate with DRS to help people try to make as informed a choice as they can and plan as best they can.
Yeah, but you're right. There is no direct subsidy. Not like the Medicare plans, which have an explicit subsidy. These members do not receive a direct subsidy to bring down their rates. We call it an implicit subsidy because they're implicitly subsidized by being rated and pooled with all of our active employees. On average, these retirees cost about 60% more than the average active employee, just because they're generally older. So they get the benefit of having the lower premium by being rated with the active employees. So while there's no direct explicit subsidy that the state contributes, they allow them to stay in that non-Medicare risk pool. But you're right, these premiums are still, I think, really hard for some employees who are deciding to retire or not.
Tanya, off the top of your head, do you have a feel of how much more the premiums would be if they weren't being rated with the rest of the population?
I don't. I think we could look at it because we kind of value what the implicit and explicit kind
But
of
it would be
subsidy is.
significant.
It is. It would be significant if these members had to, like, let's say, go out on the exchange themselves and possibly, purchase a plan or be rated on their own with their own, core cohort of retirees. It would be significantly more expensive. So yeah. Elliot?
What I hear though, on occasion from people who are in this situation is they're pretty sick, and the fact that Medicare doesn't cover them is still, the cost is pretty high for them. But I'm not advocating for them, but it's a mixed bag depending upon your circumstances.
So I think that was kind of the level of the rates we were just going to refresh on today, since we had such a lengthy conversation last week. However, we can dive into anything else if there's any additional questions. If not, I will turn it over back to Chair McDermott to walk through each of the individual carrier resolutions. And then if there is any board conversation or additional questions as we get there, we can handle those at that time also.
Any additional questions for Tanya before we get going?
Chair McDermott? I would just remind everyone, if there are no questions, that, again, because I say this and I look at Elliot because she always asks me, and so I just associate it with an Elliot question, but it's an important one, Elliot, to remind everyone. Right now, still at 9:25, no plans exist in the non-Medicare portfolio. There are no plans as we sit here at this very second for either employees to enroll in or non-Medicare retirees to enroll in. Until there is an affirmative majority vote, no plans exist. So just a reminder that until the board acts, it's a blank slate. We have a Medicare portfolio because the board acted last week, but there's no non-Medicare portfolio as we sit here at this exact minute.
Thank you.
We ready to go? All right, we're going to be voting on Resolution PEB 2025-13, Kaiser Foundation Health Plan of Northwest, non-Medicare premiums. Resolved that the PEB board authorizes the Kaiser Foundation Health Plan of Northwest employee and non-Medicare retiree 2026 plan premiums. Is there a motion to adopt?
This is Harry. I make the motion to adopt.
Thank you, Harry. Is there a second?
Second.
Are there any comments from the public? Seeing none, are there any comments from the board?
I just want to make sure I'm voting on the right thing. So as we're looking at the non-Medicare premiums, we're talking about KPNW from slide 5 and not slide 3, correct?
These resolutions are for both.
Both, okay.
We make separate charts to show for the different populations, but the resolutions themselves are for both the employee and non-Medicare premiums. So for right now, you're talking about on slide 3, the top 2 rows that are labeled with KP Northwest Classic and CDHP, and then on slide 5, also the top 2 rows, KP Northwest Classic and CDHP.
Okay, thank you.
It's all of it at once.
Because the bid rate is the same for both. The employees just have an employee and employer split where the non-Medicare has the total bid rate. So they're the same underlying rates. It's just the employees have a split.
Great clarification.
Everyone clear on that? All right. It's going to be a roll call vote, starting with Harry.
Before we do that, Lou, was there any, maybe I missed it, was there some public comment allowed?
There was public comment allowed and nobody volunteered to comment.
Okay, thank you. Well, I wasn't sure when to speak because of, I know Dave was trying to clarify when to speak if we wanted to, but I wasn't sure. So I'm not happy about some of the rates, as many people aren't, but I believe that we will need to authorize, approve this resolution. If we don't, we'll be disrupting a lot of subscribers. I mean, and especially those who have longstanding care and to choose to stay with Kaiser, and that ought to be their choice to me, and not the board's. I recall a few years ago hearing loud and clear from retirees when we had the idea of sunsetting the UMP Medicare. And they said they like the plan. We ought to find a way to fix it and let them, the subscribers, decide whether it's worth the price. So anyway, with all of that, I vote yes. Thank you.
Appreciate your comments, Harry. Kirk,
No.
Tom,
Well, I only got an out anyway, so I guess I'm good. I agree with what Harry said. I'm wondering if there is a way, we're really talking about the people that are most dramatically affected by the change in rates are the employee premiums, and we're talking specifically about 3,923 people. I'm wondering if there would be a way, since this has happened before, if there would be a way to specifically survey this group of people between now and the same time next year to get a feel for how they feel about if they're willing to essentially put up with these higher rates, or if they want us to make a change, because we kind of are in a no-win situation, in my view, where if we say no, then it goes away, and there might be a lot of people that are very upset by that. But at the same time, we don't necessarily like what they are doing. So that's my question. That's my comment. I will vote yes.
do you want to respond after? Okay. Michaela,
So I'll say, I believe that choice is important and that we want to make sure employees continue to have an option to choose. And just seeing how this plan continues to fluctuate, and I've lost quite a bit of trust, and I worry about the employees who don't see it. Like each year we try to advertise as much as we can about the changes, and the reality is that oftentimes you're not paying attention to it. And so whether it's purposeful or not, it feels sneaky in how the premiums are fluctuating so much. So I'm going to vote no.
Elliot,
I agree with everything that my fellow articulate board members have mentioned. And building upon what Tom said, perhaps even there can be a public meeting. I think just like we had for UMP, a few years ago, where people could come and voice their opinions and be heard. I think that would help, and it would make them aware of what's going on. I am very grateful to Dave, who reminded me that if this resolution doesn't pass, these people get nothing. So with that in mind, I begrudgingly vote yes.
Appreciate your comments, Elliot. Sharon.
So I do absolutely agree with what everyone said. John's comment is particularly pertinent to me because I think it's important for folks to have a voice. In that voice, they should be able to understand what is happening, how that affects their lives and livelihood. It's important to keep those voices in mind when these decisions are made. If there is an attempt to reach out to folks and hear what they're feeling and how their lives are impacted, I think that's an important posture that this group should take. I will vote yes with very, very, very strong reservations.
Thank you, Sharon. You know, it's interesting. In the entire time I've been with the program, from when I was the PEB director to today, I don't think I've ever voted no. I think one time I didn't vote, which caused a kerfuffle. That was an interesting day. I think that was a mistake on my part. I too have concerns, and I do realize if I vote no, the motion will still pass. But in the spirit of hoping things are going to get better and that we are going to do a lot of work in the off season, I'm going to go ahead and vote yes today. Resolution 2025-13 passes.
Chair McDermott, I could answer some of the questions. I feel it's a little awkward to do that in the middle of the voting motion process, but I did want to share. The board may or may not remember that a couple of years ago, since the pandemic, I've lost track of what year is what anymore. But we did start doing more annual surveys in the summer about various topics. And this year, when we went to look at the summer survey, we thought we had a couple of pieces that we wanted to kind of retrofit in the survey tool. And then we said, hey, why don't we switch this to occurring in January and have some more questions specific to the recent open enrollment, specifically asking people who switched plans why they switched to get at some more information. So that is the intent, is the next survey that we do is plan for winter after open enrollment and incorporate some more opportunities for people to answer that type of question. So that's at least one part of the toolbox. The second is, Elliot, it's a great point. We've been thinking about periodically, we did learn a lot and had really good feedback during the listening session from the UMP Classic Medicare Sunset Conversation Days. Again, that's not happening, just for the record. No closing of UMP Classic Medicare on the horizon. I feel like I need to say that a couple of times a year now. But good lessons learned from that, and we were trying to identify topics to be able to do periodic listening sessions, and so we can absolutely take that under advisement as a possible topic for looking at that next year. So that's a great idea.
If we can, this is Elliot, if we can help you with that, we're happy to. We don't want to just complain. We want to help.
Well, there was a lot of good collaboration with retiree associations for the listening sessions that were a couple of years ago. And so anytime that we would do something like that, I think there would be outreach and coordination with the various retiree associations. Yep.
All right, next up, we're voting on resolution PEB 2025-14, Kaiser Foundation Health Plan of Washington, non-Medicare premiums. Resolved, the PEB board authorizes the Kaiser Foundation Health Plan of Washington employee and non-Medicare retiree 2026 plan premiums. Is there a motion to adopt?
So move.
Is there a second?
Second,
Any comments from the public? Seeing none, any additional comments from the board?
I just want to clarify again. So we're voting on both the non-Medicare retiree premiums and the employee premiums.
Don't correct.
Yes, Mikhail,
Brian,
all 4 rows on slide 3 that are labeled with KPWA, and also all 4 rows on slide 5 that are labeled KPWA.
Is the board clear? This can be a roll call vote, starting with Harry.
I vote yes.
Kurt,
No.
Tom,
Yes.
Michaela,
No.
Elliot,
Yes.
Sharon,
Yes, again with reservations.
and Lou, yes. It looks like resolution 2025-14 passes. Thank you. Next up, resolution PEB 2025-15, Uniform Medical Plan Non-Medicare Premiums. Resolved that the PEB Board authorizes the Uniform Medical Plan Employee and Non-Medicare Retiree 2026 premiums. Is there a motion to adopt?
So moved.
Is there a second?
Second.
Any comments from the public? Seeing none, any comments from the board? It's going to be a roll call vote, starting with Harry.
Yes.
Kurt,
Yes.
Tom,
Yes.
Michaela,
Yes.
Elliot,
Yes.
Sharon,
Yes.
and Lou, yes. Resolution 2025-15 passes. All right. Thank you, folks. Yes, sir.
I have a question, just my own information. I'm curious, why Kurt and Michaela voted no on the first two. And I'm just curious, what would the alternative be, did you say? This for future reference.
Well, for all the reasons.
Mike, sir. Sorry.
For all the reasons that other board members stated. My confidence in Kaiser since I think 2023 is very low. And we see wild swings in premiums and bid rates and, you talked about surveys. I don't do a survey, but I hear from a lot of employees. And of course, they only contact me usually when it's negative, right? They don't call me and say, hey, everything's great. And especially in, Clark County and the other county that plan serves Cowlitz, nobody's happy. The options are few. Prices continue to rise and they're struggling. And I think Kaiser needs to do better. Frankly, that's the bottom line for me.
But if we voted, I'm sorry, if you guys voted, if everyone voted no, what would the alternative be?
Well, I was confident that other board members would likely vote yes.
Okay.
I am with you that I would not want to take away necessarily the option, that it's really up to those members to vote with their feet. And if they don't want to be in that plan anymore, to change in open enrollment. Maybe someday that will change for me. Maybe there will be a time I said, this enough, kill it, done. But that's kind of where I'm at.
And just so you know, had Michaela and Kurt voted yes, I probably would have voted no. I think there needs to be some message to Kaiser that what they are doing is not acceptable. And I was willing to do that. I just didn't want, for the reasons really what Harry said articulated is, I didn't want to leave 3,000 so many people out there with nothing. And so ultimately that was why I voted yes. But like I said, had there been no votes, I would have been a no vote. I wanted that message to resonate.
What I would add too is, I think oftentimes in my role, you have to make decisions where there's no good solution. It's, we choose to vote like contingently yes and give people a plan that we don't really have a lot of trust in, because there are going to be people who don't realize that their premiums have changed and on January 1 are going to go, holy cow, why am I paying so much? Or you go to the other side where there are people who need this plan for medical reasons, who are saying, why did it close? Now I have to do all this work to switch. And correct me if I'm wrong, Dave, my understanding is they won't be left without insurance. They will just move over to the UMP plan and they will have to do all the hassle of changing insurance and doctors and all of that. So it's not that I would have not would make sure if they were left without insurance, that's a different situation to me. But there are pros and cons to both. And last year I voted yes, because it was but with conversation or a message to Kaiser saying something's got to change. Nothing changed this year. So I feel like as a board, we also need to demonstrate that if they're not going to change, we're going to change. And it's continuous. We don't kind of flip the switch overnight. But like Kurt said, there needs to be a message. And to me, I feel like we're at the brink of saying, hey, for those people, and I'm not taking this lightly, that there are people that would have big impacts if they had to move over to uniform. But when you weigh that with the big impacts of those kind of astronomical increases in premiums, they start to level off, and it starts to change how I think about voting and whether or not choice is more important than unknowingly having those increased premiums.
Thank you. The reason I asked the question is because you and Michaela represent active employees, and Tom and Elliot represent retirees. And I was looking at the difference, and if it had something to do with that. But I guess I represent the taxpayers of it, consumer costs person. So my interest was really understanding the difference between how active employees would be viewing this versus retirees, since we represent both groups of workers, employees.
Yeah, thank you. And I'll just add, for all these reasons, is why I have brought up, and I will continue to bring up, the pursuit of other plans, other providers. So hopefully there are more options that employees can choose from. Bottom line for me is there's other plans out there that are able to maintain more stable and reasonable premiums. So why can't Kaiser?
I'll
Yeah,
just confirm Michaela's question, an assumption that the uniform medical plan, there would not have, if one of the resolutions had failed, the uniform medical plan was approved. That is a statewide plan, and so you are correct, Michaela, that individuals would have been able to have selected from UMP plans. They would not have been insurance-less. So just confirming that fact.
And just one little comment about, who folks represent when they're here. I like to think that we represent the entire program and that we're looking at sort of both sides. And I usually don't see board members exclusively focusing on one group and I don't really care what happens over here. We are the PEB board and we represent all the individuals who receive insurance under this plan.
And Barry, I think your hand's up.
Harry?
Yeah, thanks, Lou. I think what you just said is really important to keep in the back of our minds actually in front of our minds is that we represent the plan and its subscribers and not just an individual group. I really appreciate what Kurt and Michaela said. And Tom as well, everybody event, and I felt the same way. However, I've had some experience where we've said to subscribers, well, we've got a plan, we'll just move you over to another plan. It's easy from that perspective, but when you're on the ground, I got to go through that, as Michaela well pointed out, is rough. And so I guarantee you, we would have heard much more, in my mind, had we not approved the resolution. And with all that said, I know we're going to get a presentation on contracting or RFP process. I just got to believe there's a way to compress that. There's got to be able to find a way to do that. We were able to do that with the Medicare Part D, getting all hands on deck. And so I'll just stop my comments and say, I agree. Let's strongly explore other options and clearly put some more pressure if we can on Kaiser. Thank you for listening. Thank you.
All right. Thank you. Thank you, Tanya. Appreciate all the work this year.
Yeah, thank you, guys.
Thank you.
Yep. All right, next up, Alyssa. Alyssa's the benefits account section manager in ERB, and you're going to be flying solo today. They're going to go over the SEB program's work to prepare for this year's OE in the fall. And the presentation is also going to include some information on benefits 24/7, which I think Alyssa can cover for us. Materials behind tab number 6. You're intimately familiar with 24/7?
I am.
Excellent.
Yeah.
And now we have plans.
Yes.
As of 9:45,
Yes.
we have plans.
Phew.
So now you can begin your
Yes.
open enrollment
Yeah.
work.
So now
Get
you can
started.
start your
Now
work
get
right
started.
now.
Yeah. So good morning. My name is Alyssa Richards. I'm the benefits count section manager. So I'm going to go over how we're preparing for open enrollment. So next slide, please. So on this slide, I have a timeline of kind of the activities around open enrollment preparations. So as Dave mentioned earlier, we don't start now. We started months ago for open enrollment. There's a lot of work to do. So in March is when we start meeting with other areas of the agency to start talking about some of the items that will be needed for open enrollment, system updates, et cetera. And then also wanted to call out as a reminder, last year we did change the open enrollment dates. So it's the last Monday in October through the Monday before the Thanksgiving holiday. So just wanted to call that out. So this year that is October 27th through November 24th. And then starting in April is when we start planning for the benefits fair. So it's looking at locations, pulling some data about member enrollment so we can determine what cities to have, et cetera. And then in June, the communication team starts to finalize the communication plan for open enrollment. In July, just moments ago, you voted for rates so that we can kick off and finalize those communication materials. And then in August, we get the final rate sheets from the finance team. And then in October, you will see the open enrollment newsletters, and then the open enrollment website will be published around October 3rd. Okay, next slide, please. Right. So as a reminder, the outreach and training team works directly with the PEB agencies and SEB benefit administrators. The team supports over 700 PEB agencies and SEB organizations combined, and they provide training to these organizations regarding plan options, covered benefits, eligibility, rules, and enrollment processes. In turn, the organizations act as that first line of customer service for their employees. And when benefit administrators need assistance, they reach out to the outreach and training team directly, either by calling a toll-free line or using our online secure portal, HCA Support. The team works on open enrollment activities all year, as I mentioned, and we have been implementing a lot of improvements and feedback into our processes and activities. So next slide, please. The customer service unit is the first line of contact for retirees and continuation coverage enrollees. Staff perform 3 primary functions, which is answering that toll-free line and responding to HCA support inquiries. They provide in-person lobby services to walk-in members, and they review retiree and continuation coverage eligibility as they process enrollment forms. During open enrollment, any changes requested by retirees or continuation coverage members are submitted to the customer service team who review them and then enter those changes for a January 1, 2026 effective date. We have a total of 27 Mass 3 positions in our customer service unit. We have 25 of those currently filled. We're just wrapping up, getting the last 2 filled. And 18 of those positions will be fully trained by open enrollment. The remaining will be in some stage of training and still actively participating in activities. And then this year, we're not expecting a lot of movement. So in plans, just based on the premiums, we didn't see significant for retirees. So we're not expecting a lot of movement this year. So next slide. So
Alyssa, I'll just make a joke. I think the only people who are happier to understand what the Medicare premiums are beyond retirees is PEB customer service, because it's a direct indicator of what call volumes might be and how much support is necessary. So they are, I think they're the most active employees that are interested in the Medicare retirees, just premiums. So they were very pleased to understand what happened with the board's actions last week and understand the rate process and where it landed for the various plans.
Yes, thanks, Dave.
So every year, the outreach and training team conducts webinars for benefit administrators to help prepare them for open enrollment. These webinars will also be recorded and then later posted on the benefit administrator websites. Once the dates of those webinars are finalized, they'll be shared and advertised with benefit administrators. And then the outreach and training team, every year they do create and provide forwardable messages to benefit administrators to then in turn send them out to employees with important messages about any changes and things that they need to know for open enrollment. Next slide, please. Okay. So we received a lot of feedback, which we used to start planning the fairs for this year. So the locations are based on member enrollment data. I have included the dates, times, and cities on the next slide, so I'll go over that shortly. Based on feedback we received, we are working with our communications team to make sure that we have printed materials available at the very first benefits fair. We also, as we did last year, we have an open time for all members to come. So it's not a dedicated employee, retiree, or PEB. They can come at any time and speak to folks at the fairs. And then this year, again, we'll offer the virtual benefits fairs. The virtual benefit fairs is an online website created with the same goal in mind as the in-person fairs. Some of the features are that they can learn about benefits from their home any time of day. They can use a computer, tablet, or smartphone. And then some carriers provide direct interactive webinars, pre-recorded webinars, and teleconferences to share plan-specific information. Next slide. Okay. So as I mentioned, on this slide, you'll see the dates, times, and cities for the 14 benefits fairs that are hosted by HCA. Last year, we had a fair scheduled on Halloween, October 31st. We received a lot of feedback that was not preferred. So we definitely took that off the schedule. So you can see that we did take that feedback for this year.
You might imagine who won between trick or treating and going to a benefits fair. So we also want to provide better service. But we did receive a lot of frustrated people who were frustrated that was even a question that they had to think about, and that they wanted to be able to attend a fair, and they didn't think they should need to choose between trick or treating, either their home out or going out with their family. So we October 31st will not be a benefits fair in the future.
Yes.
It's free candy, man. I mean,
Is there?
Yeah, I can't bring my kids.
I had a quick question. Is this compared to last year, more, less,
The same. Yes,
Same.
the same.
Okay,
Mhm.
thank you.
Next slide, please. So in addition to the 14 benefits fairs that HCA hosts, we also will be attending the 4 fairs hosted by University of Washington, which is October 20th through the 23rd. And these fairs are open to all members, so not just specific to UW employees.
Going back to the benefits fair,
Mhm.
do you have multilingual folks there? When I was a benefits consultant, I was getting a lot of questions about problems that people with not just Spanish or English but different dialects of Chinese or so forth were having in communicating.
Yeah, for the HCA staffing perspective, we don't. I can check in with our carriers to see if that is something that they can offer. I'm not sure that we don't have a way of capturing preferred language, so we don't know which types of languages we should be supporting at those fairs in person. So right now we don't, but I can definitely check in with our
I'm
carriers.
just wondering if there's a best practices in that area, because what I found is that was the lower income employees who English is not the first language.
Mhm.
And they didn't understand the benefits of various health plans and in research I had done outside of that, in my own academic research, I found that non-English speakers have less utilization of healthcare benefits in the public sector. So my concern is that I don't have an answer for how to do it, but I'm wondering if there's a best practice that we could research for dealing with particularly dialects. And now with the University of Washington, we had people from all over the world
Mhm.
and who just didn't speak English.
Yeah.
So just a point.
Yeah, Alyssa pointed out we currently don't have a way to capture preferred language. It is something that is in our strategic kind of planning for the ability to be able to capture that information, but that's also going to be contingent on people being willing to give that information. And there's a lot of dynamics as to why individuals may or may not feel comfortable providing that information, but we don't have a way to capture it today, but it is something that we are looking to be able to capture, to be able to do more analysis and like you're describing, John, is to look for trends like that. That's one of the reasons that we think it's important to be able to document that information and identify even better the languages that people may request our materials in. It used to be 5 years ago that we didn't produce really very much at all of our materials in any other language. The ability to translate the materials was there, and we would get periodically, very intermittently, some request for an individual publication or form to be translated. We now get not a lot, but enough that we know that the requests are coming year over year, and it's predictable enough that we are now starting to proactively, when we finalize, for example, the enrollment guidebooks, we now kind of automatically translate those into Spanish because we know there will be a request, and we know that need is actually better. We'll be able to serve more people. So we've started to kind of move into that foray a little bit based on trends of what people have asked for. We haven't really had the question come up before about benefits fairs. But we have an eye towards this because it's definitely an area that you've pointed out where there are inequities that can happen in access and use of benefits.
Just
because
two
of
quick
that.
points. One is that I get a lot of information from Google related companies that use Google translation services. And when you get into technical areas like we're in, it doesn't work very well. Hopefully AI, as it improves, will be able to get into understanding deductibles and co-pays and things like that. But right now, Google doesn't seem to have the capability of getting into really the technical weeds.
Well, I have a great example of this. Being a Washingtonian, I think people will appreciate this one. I was curious what AI would produce, and I learned that the Cougars apparently joined the Big Ten and are playing Maryland this October, when in fact it's the Huskies. So I just thought, there's challenges with AI, so that's not even getting into deductible and copay. That's just which Washington State team is in the Big Ten, as an example. So, Kurt.
Just to add on to what John said, and thank you for raising that. At the U especially, English is not the actually primary language. We represent thousands of workers at the U. And I could help you if you need to know what the other languages are that are most prevalent, because we often have to translate ourselves. But at a minimum, if you could at least have the materials there available translated. But we also represent thousands of HCA medical interpreters that would love to make themselves available for benefit fairs, even at the U, for the more prevalent languages to help interpret. Just putting that out there.
I appreciate that. Thank you.
I guess one other question is, when I think about oftentimes low income wages are associated with fixed schedules where you have to be there in person and you can't necessarily get away from your job or have that flexibility. When I look at the time frame, do we know, and this is me just being somewhat naive, do we know if that works for people to be able to get to the fairs, or are we missing a certain demographic that might be working during that time and not have that flexibility?
I can start with
Go
this. What we do know is, so in recent years, we've been adjusting the hours that we've had benefits fairs. Especially, I think in the beginning with SEB, it went much later into the evening. I think it went into 7 or 8 o'clock. That was when we had segmented fairs, but they were hosted in the morning for basically retirees, because retirees stopped coming around 2:30, and then we would see a pickup of employees later in the day. But then as we've kind of monitored we asked our benefits marketing folks who are at the benefits fairs to kind of document some trends, not like officially, not with like a counter like at the front of a warehouse or something, but just like generally what are the trends that we're seeing. And we're seeing very low census in benefits fairs after about 4:30 or 5 o'clock. very trickling from anyone. And the predominant users of the benefit fairs outside of the University of Washington have been retirees. So we weren't seeing that amount of, like I said, census to be able to support having those extended hours. And actually, one of the reasons that contributed to scaling back to 4:30, because I believe last year they were either at 5 or 5:30, was the end of it, was actually trying to balance the administrative budget cuts that are necessary for contributing to the state's recent state budget passage. And there are very few areas administratively, and we were looking at kind of like overtime hours and length. You might even notice if you went back into the benefit fair to be like, didn't you used to have 4? You had a Monday through Thursday. We went down to that level of like, well, how much travel is added and those things to really kind of manage the funds a little bit more closely. But it was driven by census. So we weren't seeing the usage after 4:30, but we are very curious what feedback we receive this year now that we've officially moved it to 4:30 and see if it needs further calibration. But we have been adjusting the end time the last 2-3 years based on the data that we were seeing. Kurt?
I would also add too that I think most employers allow you to attend on work time, and we would strongly advocate for those that don't, that they should. So hopefully most are doing.
Okay. There's no other questions?
Benefits fairs. Always a hot topic.
I do have one other comment. Thank you so much. Being at the U and the faculty there, and this may or may not be relevant, but I know that for faculty, if they are among those that are selecting, our teaching schedules are kind of wonky. So between a 10 and 5 frame can be quite and perhaps challenging. So my question to you folks is this. Might there be any other flexibility outside of the traditional hours of 10 to 5 where faculty may not be available because of our teaching schedule, and because of some of the other responsibilities that we do have, and how have we accounted for?
Sharon, we will be happy to give UW that feedback because the 4 UW fairs, usually the 14 that are on slide 7, Alyssa's team organizes, we host the party and everybody comes, and the 4 that are on slide 8, UW hosts the party and HCA attends along with everyone else for employees. So they're setting that schedule, but we will be happy to provide feedback about that and talk with them about how, we balance that for the 14 that we host and what they're doing on there. So we can absolutely convey that and talk with them about that.
Absolutely. Thank you, Dave, because that's a real issue. Thanks again.
All right. Let's go to the next slide, please. So this year we'll have some similar communication strategies as we did last year. So we'll do social media posts, forwardable email messages with employers, as I mentioned, work with retiree associations and provide presentations. We'll have the retiree customized letter as we have in the past. There'll be an alert banner in Benefits 24/7. And then also a website alert on the front of the HCA website, so folks can easily navigate to our open enrollment web pages. This year, we'll also be sending a postcard to UMP Plus subscribers, alerting them that the plan will no longer be available January 1st, and that they can either select a new plan during open enrollment, and if not, they'll be defaulted to UMP Classic. And then we'll also send a letter to those same UMP Plus subscribers at the end of September with the same messaging. And then we'll be using the October newsletter to call out information that members need to be aware of when considering plans for 2026. The front page of the newsletter will also describe steps to take to make enrollment changes, including prominent alerts about changes for plan year 2026.
And I'll just add for UMP Plus closure, there's another part that I think is helpful for everyone to know is on Benefits 24/7 later this month, we'll have language that for people who are new employees and electing the first time, they can still elect UMP Plus through December 31st. But alerting them that if they pick that plan, they will have to move out of that plan come open enrollment. So our communications about the closure will be clear for new employees. That might be more prominent in higher education with faculty that come on in the fall quarter. or just the general hiring cadences of agencies. This is also really important in the SEB context because there is like a 10 to 15% workforce turnover that happens there every school year. And so we wanted to be ahead of that for new employees to say, yep, you can pick this plan, just be aware it is going away. So we have language about that for the people who are coming into the program for the first time as well.
Okay, next slide, please. So last year was the first year that we used benefits 24/7 for open enrollment, and we received a lot of feedback from employees and benefit administrators. So we conducted 4 focus groups with benefit administrators using human-centered design principles to review specific tiles of the open enrollment wizard, which was related to the dependent verification. You may recall if you used benefits 24/7, when you got to the dependent screens of the open enrollment wizard, you had to click the upload verification button, even if you didn't have to upload verification. It was the only way to move on. So we got a lot of feedback about that. So these focus groups focused specifically on the dependent section, and then also the spousal attestation section. So I will actually turn it over to Brett so he can talk about system readiness.
Good morning, Chair McDermott, and members of the board. Again, my name is Brett Mello. I'm the Chief Information Officer for HCA. Thank you for having us here today. The first bullet, if you can forward this, oh, well, there we go. System readiness there. All right. The first bullet there about the open enrollment wizard updates is what we just spoke about. So the changes from those sessions are planned for implementation by OE for the plan year of 2026. So not much more to say than that, what's already been covered. The UMP Plus wind down, team has begun work on the UMP Plus wind down and is currently on schedule for completing work by open enrollment. We're actually finalizing test plans now. So as far as annual updates, a few weeks before OE, HERB provides the benefits 24/7 and the Pay One teams with a updated rate sheet for the plans that will be available along with any changes to plan availability, which is then implemented in the systems. The screen text in benefits 24/7 is reviewed by HERB and the communications team for clarity and accuracy. Generally, this is to address any legislative, board, or program changes that have occurred, though sometimes this includes adjustments to make the system more accessible based on user feedback. All updates are provided to the benefits 24/7 team for implementation in the system. And then, of course, we're continuing on with any bug resolutions that are required, especially high priority issues, making sure that we're addressing the data quality and processing issues in a timely manner, and we're staying on top of those. And then finally, user acceptance testing, sort of the last piece of the puzzle before we go live. And we're in the process of planning our OE acceptance testing with the business and making sure that we're ready to do that piece when we get there. So those are elements from my team. Yes.
I realize this isn't your team and you'll likely still be the face of it for folks. Are you doing anything to connect with WATEC or to ensure that, because I know a lot of people have trouble with SAW, where it might be they haven't accessed their SAW account since the last time they had to log in for benefits 24/7. So
Absolutely.
just preparing you for that too, even though it's not necessarily within your scope of control.
So they are replacing the SAW login component. That transition is available to do, but we are not going to do it until post open enrollment, just to make sure that we don't have any issues and challenges with going to a new platform. I think their strategy and where they're going is really good, but for right now, we are just making sure that we are staying completely focused on making sure that OE goes smoothly and not also having to deal with any kind of security or access issues.
So to Michaela's point, I believe previously we asked WATEC to keep their customer service hours open longer so that people after work, when they tried to get in and had problems, they could call. Are they doing that for us this year?
I do not know. I will have to get an answer to that.
Alyssa, do you know?
I don't know that it's been done yet, but we will definitely make sure that we do that, and have the conversation. And then we also, usually we reach out to WATEC ahead of time to give them our open enrollment dates, just to make sure that they don't have any scheduled maintenance, during that time. So yes, so we will be working on that as well.
Okay, and let me know if you need any assistance with that.
And just on the point of, because I saw Elliot get excited that we were saying Saul might be changing, and then we said after open enrollment, I think we are at least all generally aware of some of the challenges that happen, and we don't want to inject new unknowns into this open enrollment. We'd rather work with the challenges we know instead of the challenges we don't know. And sometimes it's best when things are unrolling to go first, and sometimes it's better to go last. And so we're opting to. Agencies and entities in the state have the flexibility of when to migrate over to the I'll call it SAL, the post-SAW transition, and we've opted just to be in a later cohort of that adopting, so that we can be through this open enrollment and then be able to address it better in OE fall 26. So,
Any additional questions, comments? All right.
Next slide. Okay. Thanks, Brett. So there are some ways an employee can prepare themselves for open enrollment. For employees considering changing their plan, the best way to prepare is to make sure that they can log into that Benefits 24/7 account prior to open enrollment beginning. Consider signing up for email communications, write a list of important questions they may have for plans about benefits, prescription costs, deductibles. Members should make a list of prescriptions so they can work with plans to understand how they would transfer those prescriptions, as well as what prescriptions costs would be. And one of the most important ways a member can prepare is to read the materials and review the changes for 2026. So there will be important information included in the October newsletter and the HCA open enrollment web pages to help describe changes in benefits and costs. And as I mentioned earlier, those open enrollment web pages will be available October 3rd. So next slide. Once members have reviewed changes for the year, they should also go in and make the change if applicable, waive or make changes or waive, add or drop any dependents, attest to any applicable surcharges, elect the flexible spending account or limited purpose FSA dependent care assistance program, complete the smart health incentive, review life and long-term disability coverage, and designate beneficiaries. There will be a lot of helpful information and tools on our open enrollment web pages that will help members make the changes based on their decisions made.
take a quick opportunity to stay on this slide. Couldn't think where else to say this, but DCAP is mentioned in the middle of this slide, and wanted to update folks. The Dependent Care Assistance Program is and FSA benefits are part of the PEB and SEB programs, but the authority for the benefit design and the structure and administration of that particular benefit is with the agency under state law. And recently we learned that as part of the federal legislation that passed earlier this month, that although it wasn't really in the news, and it's hard to find even when you know that it's actually in the bill, the cap on DCAP benefits was actually increased in that bill. So for the last 40 years, because the original enactment of DCAP was part of the COBRA legislation in 1986, the cap on that benefit has been that you can elect up to $5,000, and that was never indexed to inflation or consumer price or anything, unlike other parts of tax preferred benefits that exist federally, like HSAs, or even the FSA benefit. There was no indexing to anything, so that $5,000 benefit from cap from 1986 has persisted, with one exception, the year of the pandemic, where there was one-time relief where you could have essentially double that. But then it reverted back to the $5,000 that's been in law since 1986. But it is now increased as of January 2026 to $7,500. So a slight improvement, maybe an extra month and a half of expenses that could be used with tax preferred dollars. So we're going to be implementing that part. And that's my entry point to say there's still a lot of things to understand about that bill, and about any other action that the federal government takes or agencies take as they're implementing various policies. I fully anticipate we'll have more discussion about things that we've all learned in that bill and how it gets implemented when we come back next sports season in January. I think that'll be a great part of the retreat, and just sharing with you, we're all learning different parts of it. That was one when it came to my attention. I was like, wow, I've been pointing that out for years. I have a little template that even anytime a federal official asks, I was like, here's where you find it. If you need to amend the statute, this is where it is in the United States Code. And here we are. It's finally changed just a little bit. So just wanted to give an update on that as well. That's another small change that's a part for 2026. You turned it off.
Okay,
Okay.
welcome to old age. Yeah, I need somebody. I need a manager. I really appreciate this enrollment member checklist. I think it would be great to have it more available to, like, I sent it to RPEC, who I represent, because I think it's really good. People aren't thinking about this all the time. And if they have a piece of paper, oh yeah, and they can. So if you could maybe put this on your website or something like that, I think it would give people something that they could check off, and of course add to it, but yeah.
We will definitely take that under advisement. And I also say the last one on the checklist is always really important. And I will advocate for designating beneficiaries. I said yesterday at SEB, I recently came across there's great marketing opportunities when it comes to designating beneficiaries. It's all about where you want various benefits to go if something happens to you. And a lot of people set it and forget it. And so the DRS, Department of Retirement Systems thing that I saw earlier this week was if you made your own acid washed jeans, it's time to check your designations for your beneficiaries. And I've been thinking, about it as like, if you remember Mount St. Helens blowing up, it's time to check your beneficiaries, your designated beneficiary. So we'll always be pushing for people to make sure that they do that. It's a very easy process. I personally actually got motivated to do that earlier this year, and I decided on a Monday that I was going to do one thing, and then by Friday I changed my mind, and I changed it twice in a week. It's really that easy. So it's a really important thing for people to do, and we'll keep emphasizing. No offense to the jeans.
Next slide. Any questions? Any other questions?
All right. Thanks, folks. Appreciate it.
Thank you.
Why don't we go ahead and take a 10-minute break? It is 10:19. Let's call it 10:30, and we will get back to John Parton, who's going to come and give us a presentation. All right. Next up, John Parton, Benefits Account Section Manager in the ERB Division, is going to go over the agency's process for conducting what we call an RFP, a request for proposal. And John's presentation basically is in response to board member questions from earlier in the season. And so he's going to give a in-depth explanation of how that process works. What are some of the complexities, why it takes so long? A lot of people are always curious about, like, why would that take so long? It's like, well, there's a lot of steps, and we're going to hear about what those steps are today. Thanks, John. And materials behind tab number 7.
Thank you, Chair McDermott, members of the board. Appreciate the time today. As Lou said, going to walk through at a high level what the process is, how long it takes, and then what some of the key components are that are part of it. So if we advance to the next slide, please. And to the next. So first, what is an RFP, a request for proposal? These are typically used when we have a new contractual relationship or a completely new benefit design or plan offering that we're going to bring to the market. Key points here is that it's very structured, and I will underline, even though it's not underlined on the slide, regulated and a formal process. The reason I call that out is that it's important to realize this isn't just something that we at Healthcare Authority are determining the parameters of, right? There are multiple regulatory requirements for these types of public RFPs to determine who vendors are that we will select and work with. That's not an HCA thing, that's a state set of regulations. all of that is in place to ensure that we have a fair and accurate assessment of proposals and that we have a defined process that we follow to assess those proposals when they come back in. And I want to really quickly just reference, there are a couple of other related processes that we're not going to go through today, but they're important. One of those being decision packages. We often talk with you all on the board various points in the year about developing decision packages that are basically asking for authority to do things, right? Or the funding to do things from the legislature and the governor's office, particularly the legislature. And that's assessing the financial impact of what we're planning. And there are also requests for information, which usually predate the RFP. It's where we're looking for what's out in the market that will help us craft the actual request for proposal. So next slide, please. This is the process portrayed graphically. The important thing here is that you look at the top, the total timeline typically takes 2 to 3 years from beginning to end to go live when we actually have an effective date. And there's work that goes on even after the effective date of the plans being implemented. It's broken down into 4 major buckets, and I think these will help us kind of walk through the process. One is the development of the actual RFP. What do we go through to get it prepared and ready to go out to public and for vendors to respond to? Vendors respond, then we go into the evaluation stages. So what do we do with it once it comes back? And then once it's through the evaluation phase, go into negotiation of actual contracts, defining the contractual relationship. And once that's successful, we go into the implementation planning. And we'll go through each of these in some detail, but just wanted to give you an overview, and we'll come back to this at the very end to answer the question, why does it take this long?
Elliot, ASB stands for apparently successful bidder. I just suspected. And yesterday I had to mention it at SEB. I was like, Elliot's going to ask the acronym.
And we
apparently successful bidder.
We call it that because it doesn't mean they're going to get a contract. It doesn't guarantee they're going to contract. It's just that they are the apparently successful.
So-
apparently it looks like them. And then we begin negotiations and go through that process.
So great questions. We can probably skip slide 17 when we get to it. And there's, well, we don't need to get into the difference between what the A actually stands for, apparent versus apparently. There's, as I tell my 8-year-old, words matter, so choose them carefully right now. But anyway, next slide, please. Words matter no matter how old you are, yes. Words have meaning. Okay, so this is that first development phase, typically 12 to 15 months, and the components that lie under it. I'm not going to spend a lot of time going through those here because the next couple of slides give the detail. So if we skip to the next slide. There's typically a formal project management structure because these are very multifaceted endeavors typically. We always want to start by defining what the strategic vision is. What are we trying to accomplish? What's success look like as the result of the RFP? What goals are we trying to hit, and what requirements would we have of the relationship and of the vendor that we're looking to do business with? We write the RFP, we draft contracts at the same time. So we're not waiting until the RFP is out to start writing the contracts based on what's in the RFP. And we have a myriad cross-functional team of subject matter experts that are working on both pieces of this. We communicate regularly, have multiple reviews, and incorporate feedback from our healthcare authority leaderships teams, the assistant attorney generals, looking at it from a legal perspective and a compliance perspective, Office of Financial Management, and obviously the governor's office. Also during this period, we're talking with you, the board, about it, right? Typically, by the time we get to actually issuing an RFP, you've already heard about something that we're planning. And as we go through this process, we're bringing you along, educating you about what's happened, who's responded, how they've responded, so that it doesn't catch you off guard when we come back asking for board approval. And we'll get to that later in the deck. Towards the end of development, we obviously finalize the RFP documents that are then ready to go out to the market for responses. Next slide, please.
Elliot has a question. This
Yep,
time
Elliot.
I don't know what it is.
What is the role of the business sponsor? Can you give me an example?
Yeah, so a business sponsor is typically someone that is in a functional area that's significantly impacted by the results of the RFP. And so they're representing the business interests, not necessarily just the financial piece, right? But what business challenges or goals are we trying to meet, and how is that going to fit? They're also looking at it from a very strategic level of what the administrative lift will be to the teams that are involved in implementing the program or the plan in this case. Great question.
So often in our procurements, I might be the business sponsor overseeing kind of giving executive oversight to the entire procurement process for that. Or sometimes it might be Gene Bowie, or sometimes depending on the scale of the procurement, it might be a collaboration of several senior leaders. So it might be a tag team of me and Megan Atkinson, the CFO. So it's usually a higher level senior leader individual that's kind of overseeing and making sure that as issues need to be adjudicated, or are we going left or are we going right, that there's a kind of a, and the other thing that I think about with business sponsorship is it's breaking the log jams. You know, in many projects, the role of a sponsor is to where are you running against resistance, and how do we get past that to keep the project going?
Okay.
Another way I would put it, Elliot, is that the steering committee is providing a lot of that strategic direction, but there are multiple folks on that steering committee. That part of the role of that business sponsor is when we can't get consensus among the steering committees to drive to a consensus or a decision. And if people can't agree, then ultimately that's the decision maker. But there's a lot that goes into that, obviously.
I'm glad you explained that, because I thought, well, is United Healthcare involved in this? You know, okay. I appreciate the clarification.
The entire RFP process is internal to the agency, with the exception of sometimes there are consultants that are contracted on for more subject matter expertise on a particular aspect of a procurement. But generally, it's internal state employees that do all of this work.
So, I have a question. Isn't it, Dave, at our retreats every year, usually one of the last agenda items is to ask the board if they have anything that they would like to submit as an RFP? And I know that when that happens, sometimes we all kind of look around at each other like, you know, the process is a little bit stunted for me, because I haven't thought about it until that very moment when you or whoever is speaking says that. So I'm wondering if maybe having something like this where we talk about it at this point in time, so that between now and the retreat, we could think about some of these things that maybe we would like to see, and then make those requests in January.
So, Tom, there's a couple of different times. I think you're specifically referring to when we talk about the benefits review cycle for potential onboarding of benefits. That can be part of an RFP process, or it might not be part of an RFP process. Regardless, your point right now, I think it's very clear based on earlier today and questions earlier this season that the board is very interested in if the agency could pursue a procurement. Your sister board made similar comments yesterday. So if you know, no time like the present, Tom. If there are things that you are interested in conveying and want the agency to be understanding and ingesting for any possible theoretical future procurement, and this presentation is a great time to add it. Calling me later is great to add it. Bringing it up at the retreat, great to add it. No time like the present. So if you have thoughts today about like, oh, you know, if there were a procurement, you're all asking, this presentation is a response to questions about more options and breadth in the medical portfolio. If you have, you know, specific ideas, thoughts, strategies, points you want conveyed and considered in that whole process, you know, we're not here announcing an RFP today. We're talking about the academic exercise of an RFP, but you as board members clearly have some conveyed and you know, strong interest in something like this happening in the future, because it can't happen literally in the present. But if you have strategic insights or desires or goals that you want considered, feel free to bring them up throughout this presentation. Oh, John,
Yeah,
go ahead.
I'll be the first. Is there a dollar amount that triggers an RFP?
No, it's typically. No, typically what triggers, well, okay, yes, there are. I mean, not in our world, but RFPs in general, yes, there can be. Healthcare Authority, procurements with the PEB program, it's usually other. There are certain thresholds where if you're underspending a dollar limit, you're able to do more direct or sole source contracting without an RFP.
That was my question. I mean,
I
first.
honestly can't remember if it's 10 or 50,000, but it's
No,
so
it's
small.
been increased. So it's $30,000 unless you're a certified minority or diverse owned business, and then there's a $40,000 limit.
Otherwise, it has to go through the RFP process.
And that's why I don't remember those thresholds, because the procurements we spend are up significantly above those thresholds.
Okay, my second question is, let's say there was an emergency situation, and I'll use the example. Let's say one of our carriers decided to drop out in July. And we knew that we're gonna get all kinds of calls when we came out and published the rates. And you needed to hire an outside call center. And that's an RFP, let's say that's a couple of million, more than a couple of million probably, dollars. Would you go through the same process? Or do you have a process for that kind of situation?
Lou, do you wanna?
Yeah, I mean, there are mechanisms that are in place for exceptions, like everything, right?
Yeah.
There's always the rule and then there's the exception process. And so Department of Enterprise Services, they kind of control the contracts and they give us the authority to sign contracts and do. So let's say we were in a massive bind and something was going to happen and the RFP process was going to be too long and we wanted to go with a sole source and we had good justification and we had good backup from the governor's office and everyone was feeling like this is the right thing to do, we could make that happen.
Okay.
But everybody has to sort of say yes together.
I was just thinking of that particular case. There may be others, but that would be one where if we dropped a carrier, it's July now, you can't go out for a whole new sourcing. But we know we're gonna get a lot of
Yep.
calls.
And of course, I would imagine the administration, whether it's DES or the GOV's office or OFM or whoever, would push back and say, can you gather internal resources to cover that timeframe? So we would have to really demonstrate that we can't. We are in a situation where we're absolutely stuck and we need the exception. And normally they would say yes.
And to your point, Lou, internal resources may include other existing contracts that the agency has that provide similar services.
Exactly.
Or your specific example was like call center support. Like if we had an agency contract, but it wasn't specifically for PEB or SEB, is it one that could be leveraged in a short-term capacity? But again, as Lou said, DES and the governor's office would all kind of have to sign off that that's a permissible leveraging of that. And if this agency didn't, for call centers, there are call center contracts in the state. There might be a centralized master contract with DES that says, here's a way to, it's like pre-clearance that they have done a procurement to create a list of vendors that provide a certain service. So depending on what it is, we might be able to leverage that master contract, which is an expedited process. That's not the case for like a health plan, but it might be for call center services, for example.
And we would also need the money.
Right.
There is that piece. Yep.
But I think that there's a good part that came from this question is DES is the central state agency. John referred to that there's this regulatory environment by the state. DES is the watcher of how procurements work in the state. And they subdelegate authority to agencies to do procurements. And if an agency proves to have challenges in pulling off procurements in a fair manner, DES can revoke that authority and run the procurements themselves. So that is, when we talk about a regulated environment, that is one of the functions of the Department of Enterprise Services. Kurt, do you have a question?
Yes.
Or comment?
Both. I mean, I won't pretend to know how this process works, other than what you're explaining, so thank you. This is the first time since I've been on the board that we've covered this topic, but it's disappointing that it takes 2 to 3 years to provide additional options for employees and retirees that are in need of that very thing. So my question is, I can understand this for a brand new player. And there's some out there, I think you mentioned them at the last meeting that, but for example, somebody who already has a SEB plan, I think Primera might be one of them. Could this not be much shorter when you have a player already in the system who've gone through this that, at least in the short term could be an offer, and maybe we continue this process for the new players? Maybe that's a ridiculous question. I don't know.
It's not a ridiculous question. Part of it stems with like the original procurement that happened and what authority was there. So if we hosted a procurement in 2020 to for a specific function to say, let's say that the original procurement said we were going out for here, I'm going to try to take it completely away from healthcare. Let's use the FSA DCAP benefit. So we have an administrator, Navia, that this agency contracts with to administer that benefit. When we went out for procurement last time, we said, this is for FSA account administration, this is for DCAP account administration, and we reserve the right under this procurement to ultimately include in the contract running of HSA accounts. Because currently the structure is that HSA administration is a subcontractor of our medical plans. It's not a centralized service under a state agency contract. We were primarily focused on FSA DCAP, but we reserved the right to also include HSA. Go back in time 10 years ago, we didn't reserve that right for HSA. So the original authority for the procurement 2 procurements ago, we wouldn't have had the ability to expand the scope because it wasn't envisioned for bidders at the time they were responding to the procurement to understand what was at stake with whether they engaged or not in trying to bid for those services. So some of it relates to the overall authority that existed when the last procurement happened. Now, in this instance, when we did the sub-procurement, medical procurement for the launch of the sub program in 2018, we specifically envisioned that those contracts might be leverageable for the PEB program, and we put that in the document. That procurement was in 2018. We did have some negotiations to possibly bring other carriers. There were 2 actual contracts that are in PEB in SEB that aren't in PEB: Kaiser Washington options, PPO plans, and Primera plans. We did have some conversations. They predated you on the board, Kurt, but there were conversations. There is a point, though, even if the scope of the original procurement envisioned the potential to leverage, that you were so far removed from it that has become, there are legal risks about leveraging that opportunity. We're kind of 7-8 years away from that original procurement. There was an attempt at migration that didn't succeed, and the reasons that it didn't succeed, there's not a lot of substantial enough differences today from those conversations 4 years ago to think that the outcome would be particularly different. So yes, there's sometimes ways to shorten things, but even when you implement with an existing partner, when you're doing like these procurements, part of it is to reboot contract provisions. It's to modernize the performance guarantees, to change the expectations that you've learned in the last 5 years or 7 years or 10 years since you did the last procurement, that even when you're implementing with an existing partner, it still has a long implementation standpoint. There are things that still take time. I'm not sure how satisfactory that answer is, Kurt, but those are some things I was thinking about. Lou?
Yeah, and some additional information on that. So could we do a quick and dirty? Sure. We could whip out an RFP in 2 weeks and get it out there and do our thing. But the ramifications of that, the protests, litigation, all those things could wind up dragging it out so much longer. Because while in the private sector, you can just pick someone and say, yeah, you're a good partner and we're going to do a contract with you. We can't do that. So even if we were to go back to those 18, there may be litigation and other things that said, nah, we don't think you can do that. We don't think that's fair. So the process is put in place, 1, to make sure we're dotting all the I's and crossing all the T's. 2, that it is fair and competitive and people have an opportunity to bid on these things. And 3, to actually do a good job for the taxpayer and make sure that it's a very thoughtful process. RFP development is something like you've never seen before. It can take almost a year to develop the original document that goes out and asks for the services. And the RFP is usually incorporated into the contract. So we have the RFP, we have the contract. There are times where we say to our vendor, hey, why aren't you doing this thing that we thought you were going to do? And they're like, well, we don't see that in the contract explicitly. And we're like, yeah, but the RFP had that in there. So the RFP is actually a component of the legal
Order of precedence of
yeah,
When
legal
in doubt,
agreement.
if there's something contrary, it's incorporated by reference into the contract
Yep.
as another point of being able to cite expectations and performance under the contract. So the development of the RFP, I think, Lou, you're getting to, the RFP lives long beyond the document that is the request for proposal, lives long beyond the actual evaluation process that results in an apparently successful bidder contract. It actually is an exhibit that is incorporated for enforcement of the contract for the duration of that contract.
And there are times when, for whatever reason, the contract's silent on a particular issue, but the RFP contemplated it. It just never got sort of codified in the contract. And as we run into that rub with our partner, we can go back to that document and be like, oh, no, we kind of said that we really needed this thing. And you kind of said, yeah, you could do it. So it is a brutally long process, and there is nobody that would wish it was faster than our team because it is a long, long process, unfortunately.
Michaela, and then Harry, we do know that your hand's up.
Oh, sorry. And this might be too preemptive, but just thinking about all that we've run into with kind of the ups and downs of premiums and all that, like, is there a way to build that into the RFP? Okay.
Yeah, so the RFP contemplates what's been working and what hasn't been working, right? And when we're looking for other options, that's part of what we want to make sure isn't just in the RFP, but becomes part of the contract. What do we need to change? Yeah.
Yeah, the contract can almost say anything as long as it's not violating the law. And if both parties agree to it, then that's what we do. And I do believe we have cost containment trend components of many of the contracts that we have. So it controls the cost increases and it contemplates them. And some contracts even kind of front load expenses, some push them on the back end. It might be you have a multi-million-dollar implementation that we don't have the money to pay up front. So we spread that cost out through the rest of the contract during its duration. So yeah, the contract, and I think that's definitely going to be an area of focus this time.
And then sorry, just one other follow-up. Can it take into, like, when I think about bidders, and oftentimes you have to only evaluate what they provide you when they submit, can you take into account historic performance when you're assessing a contract or a bid?
I would say not in the actual assessment, but that's part of what is so important about the crafting of an RFP is you can create the RFP to ask questions and seek insights to try to address or reinforce positive behavior. I mean, you're using a negative example. I'll give you it can be the opposite. It'd be like, we need to reinforce this positive behavior, and how can you contribute to ensuring that X, Y, and Z happen? And so it's, we actually go through some, training to root out bias, because that's one of the things. It's fairness and accuracy and competition. So it's, that if an existing vendor is an apparently successful, or that might help color some of the negotiations, but not part of the evaluation process.
So let's say, just one example, you've been hearing in the news a lot about denial rates and insurance companies with denial rates. That could be a legitimate question in there. Show us the last 10 years of your denial rates and the number of claims you received, because we're saying we want a certain thing. Can you do that? And they're like, yeah. But then we look at their history and we go, but your denial rate's 70%. So how you're saying you can do it, how is it going to be different? And then that's fair game for us to say, how is
2
today?
points for you, 10 points for you.
Well, yeah, that as well. But it's also fair game to say, how will today be different than yesterday? Because you've demonstrated yesterday.
And so I would say those were, Lou and Dave both mentioned this. They're in both the RFP, and it's also covered in the scoring, right? What's important to us, what's been challenging in the past, what's worked really well. Those are going to be the questions in the RFP are designed in many cases to draw that information out and then allow for the assessment, the unbiased assessment of, if we compare apples to apples in this current RFP, what do we think the end result will be if we were to choose them as a ASB?
Sorry, one more follow-up. When I think about like the 3-year time frame and just like how long that is, will bidders know some of that criteria early on so that as they're like formulating what their response could be, that they can help shift their behavior or like incentivize them to go, oh, okay, this is what we need to focus on so that when we put the bid in, we can make sure that we're closest to being able to have a close to a successful bid.
I think what you're describing, Michaela, is so still trying to have this as an academic conversation, but for illustrative purposes. Again, both this board and the sister board are very clearly expressing hope that the agency can proceed with the procurement. There's lots of different steps that go into that. So I keep talking about it in an abstract, academic, hypothetical sense, but there will at some point in time in history be another procurement for the medical portfolio. And when that happens, there's going to be this phenomenon of having to continue working with the existing portfolio so that it dovetails with the launch of the next slate of the portfolio. So we'll have current slate A of benefit plan offerings and a future state that is slate B that is not identical to slate A. And both the agency and the boards will have to manage the conversations about both of those at the same time until the cutover happens in that scenario. So there is some natural overlap. It's very possible that people can modify how they're doing things while slate A world is continuing on as there's a transition to slate B, but it's not that's just kind of a byproduct of what has to happen in real time. But it's not specifically ever really a goal, if you will. But it is a reflection of what can happen.
And I think it's also, I think that our partners that we're working with today, they know what the pain points are. And so as we develop the RFP, of course, they're not sitting in the room while we develop the RFP, but then the RFP gets released. And so from the release to their response to the scoring, to the written, the orals, to the announcement, to contract negotiations, to implementation, there's a whole bunch of stuff that has to happen there. And there would be not a lot of time. If we released an RFP that had some really unusual thing in it they had never heard about, there might be time for them to start making that adjustment in the process, but it starts happening quickly from our perspective. I realize it doesn't feel quick, but once the scores are done and an ASB is announced, things start happening very quickly. So I don't know if they would have an opportunity to adjust their current business practices to meet that, but they definitely would have to start planning because that's all part of the implementation plan. And a good example would be with our contract with Regents. We had a contract with Regents for our third-party administrator, and then we did an RFP. Regents won that RFP, and there was significant implementation issues, but not issues, but significant implementation activities that had to happen and it's our own partner that we already work with. Between the day they got announced, the contract was signed, and all the changes that had to be made up until go live. And that was with someone we were completely familiar with and worked with for years. I didn't hear you.
Let's go over to Harry and then we'll come back to Kurt.
Okay, yeah, thanks to John and everybody. I appreciate the information. I guess I just have an observation and really a question. The observation is, I mean, this isn't really the first RFP or procurement process we've gone through, not the first rodeo. So there ought to be, when we go back to an earlier slide, it kind of shows, segments out, time periods and all that. Some of that ought to be able to be compressed I guess that's just my opinion. Might not be correct, but it's my opinion. But really the point I want to get to is what causes the decision to start the request for procurement. So we're sitting here on the middle of July. Are we going to come back in January and say, well, okay, we talked about it, but really, nothing's happened? I mean, what causes it to start? So if it does take 3 years, it takes 3 years from today and not 3 years from next July. Thanks.
Yeah. Sorry, I just turned my mic off. So this board doesn't have to take an affirmative step for a procurement to happen. There doesn't this question got asked yesterday at sub 2. There's not like a motion that needs to happen here or a resolution that needs to happen. The agency, because DES is delegated and given the authority for the agency to proceed with procurements, can work towards the overall conversation that happens. We always say the authorizing environment, which is the conglomeration of the legislature, the governor's office, OFM, the royal kind of expansive part of government that kind of is engaged with large topics like healthcare, to proceed with going out for a procurement. John also had highlighted, we're not really going to talk about this too much, but there's a collateral effect of like decision packages. And some people may say, well, what costs are there to doing an RFP? If RFPs happen all the time, why is there additional costs? There are parts of the RFP development that are absorbable within staff resources. But when it comes to implementation, there might need to be additional project management because you're managing, multiple work streams with multiple partners, especially in the context of like a healthcare contract where you have multiple carriers that you're engaging with to kind of track the milestones that need to be hit. Although we have more robust IT resources as a result of this last legislative package to kind of have a broader IT team, there might be one-time system enhancements that have to be paid for that need accounting. So there is this effect of a decision package. The legislature doesn't have to authorize an RFP, but if there are expected expenditures that would need to be funded, the decision package process is seen as kind of an implicit endorsement or curtailing of a procurement. So the legislature at any point could say, don't do a procurement, or they could say, yes, here are the funds that you requested, which is an implicit endorsement of a procurement. So there's not a single kind of per se step, but the agency is kind of the maestro, if you will, looking out in the orchestra and trying to kind of calibrate everyone into moving forward in a process. We're clearly hearing from the boards, both boards this season, that there is intense interest in how to go about a procurement on the medical portfolios for the plans. And so that is something the agency is taking away from this board season. It's not something that, again, you have to take an action on. Your words and your questions this board season and the sister boards are very clear that there's intense interest. And so now it's incumbent on the agency to discuss with the other parts of the authorizing environment, kind of like the aspects to how and or when to do something. And like I said, it's not really a matter of if, it's a matter of when. There's going to be some sort of procurement at some point in the future. We can't go decades without a procurement. That's part of state government's procurement laws are to have periodic market checks because things change and the market changes. And so it's not a matter of if, it's a matter of when. Between now and 2040, there's going to be a procurement. I just picked a date out of it there. There's going to be procurements. Harry, I don't think you have to worry about delay in a timeline from now until the board retreat. Like the conversations in the off season with the authorizing, we've clearly heard from the boards the interest in this area. And if there is enough conversation with the authorized environment, then something can proceed.
Okay, so I had one question, now I have two.
Oh, great.
Just to drill down a little bit on Harry's question. So when exactly does the 2 to 3 year time frame start?
I think, let me try to answer your question a slightly different way. Because I did say this at the sub board meeting because it was asked kind of in a slightly different way. Like, it's possible to hit a 2028 timeline. That's 2.5 years away from now. So 2 to 3 years. That is the earliest that could be hit at this point. But I think some people might be looking at this and going, 2029 is the first time that it could be hit. There are mathematical possibilities and timelines that a 2028 launch could be hit, but a 2027 isn't possible. Is that helpful?
Even though the time frame is 2 to 3 years and it's 2025, you're saying 2028 or 2029. I understand 2028 would be 3 years or two and a half, I guess. Yeah.
We're saying 1-1 of.
1-1. Because remember, that's another thing that's important about this is there is a fixed point that is, January 1st and the start of the plan year is a fixed point in time for the programs. And then there's open enrollment 2 months before is a fixed
But you got to
point.
get it done.
You have to be done in order to hit open enrollment. So, that's really just over 2 years from now, because we normally we have to have rates out of the board in the July area in order to hit open enrollment. So when I say there are mathematical possibilities to 2028, that's acknowledging that plans are authorized and rates are set in summer, July of 2027 in order to hit a 2028. That's a mathematical possibility.
Okay.
I think it's good to point out too, the Healthcare Authority is going to have a new director on August 18th. That is the start date. And that if Dave were to stand up and say, hey, I'm going to go do a new procurement before then and start drawing on agency resources, because it isn't just Dave's team that's going to be doing this. He's going to be pulling resources from all over the agency that are going to start working on this from every single area, from finance, from comms, from a policy shop, everywhere. And so
IT.
yeah, clinical IT, it just, the list goes on everywhere you can think of. And so if he wants to do this, if he says, yeah, let's do that, the director is going to need to take a look at everything that's going on, and with the federal government doing their thing, that's been challenging. We're also going to need to put in a decision package for additional resources. Just the actuarial analysis alone, very expensive.
Yeah, I had mentioned IT infrastructure.
Yep.
Actuarial analysis is another great classic example of an RFP
Yep.
cost.
But I think this would be something that would be on the list for the new director to get briefed on pretty soon, immediately, almost, when they come in on the 18th. But we also have to remember somebody's coming in from Maryland, and we're going to be introducing them to Washington State. All the providers, all the associations, PEB, SEB, Medicaid, DBHR, all of it. And so we got to figure out, how are we going to engage this new director, and how are we going to line up these requests and to say, we want to do this, what say you? And that's, and we're still working through that.
Just that, and by that he means the general transition.
Yep.
To the new director. So there's different. I was trying to maybe reassure you that 2028 is a possibility. I think some people think that 2029 is the earliest mathematical possibility, but 2028 is a mathematical possibility.
Okay. So I still have a second question, and I don't want to belabor this point too much, but so is the idea is that we're going forward with this, or we're waiting for the new director to authorize going forward? What can we expect?
So I can't sit here today to commit to a specific procurement timeline. I'm trying to convey that and when I say I, me, my team, everyone clearly understands that both boards strongly want as fast of a timeline for expanding choice in the portfolios. And that is a loud and clear message that, Luz described some of the complexity of switching directors. We engage other parts of our environment that includes, potential legislative forces through a decision package. The decision package process for the next cycle lands squarely in the month of September. So that would be a manifestation of decision making and the moving forward of this process. If there were something in the decision package process, because the agencies produce decision packages sometime in mid-September, and then those are part of the governor's budget process that culminates in a proposed budget that happens in mid-December-ish, and then that leads through the legislative process. But I think I'm not sure how else, I can't sit here today and say yes because there's many other players that have to chime in on it. It's not just the new director, but the new director is an important part of it.
Yeah, and I think, when I remember when I took over PEB and I was trying to understand the relationship between the board, the agency, the executive branch, the legislature, everybody, it took a little while. And so my best way of saying this would be, we think it's a good idea to go forward with a procurement. The new director comes on board and we say, we think it would be a good idea. They say, well, what will that take? It's like, well, we're going to have to put in a decision package for money. We're going to have to do X, Y, Z. They say, yeah, okay, let's do that. So now we've gotten through gate one. So then we develop the DP, we send that over to OFM. Now OFM is dealing with budget shortfalls, they're dealing with X, Y, Z, whatever it is they're dealing with. They say, yeah, we should do it. Let's put it in. So they put it in the governor's budget, they make room for it, and now it goes to the legislature. Now you got to get through the Senate, the House, and the conference budget. So it gets through all those. Now we have the money. The whole time we are working on it within the resources we have, but then that money comes in, and that's going to help shore up some of those other costs, the IT infrastructure costs, the costs associated with Milliman. So, or actuary, but our actuary is Milliman, so Milliman. So then we go through that part. Now the legislature has said, okay, and then we are in motion. And then usually at that point, it's happening. You know, all signs are green. The governor says, or our director says, I don't want to do that. But the governor's office is like, yeah, we want to do that. Put in a DP. Okay, so we put in a DP for it, gets in the governor's budget. Now we're back on cycle. Our agency director says yes. Governor's office says we can't make room in the budget.
Great
Now-
idea,
Yeah.
not this time.
However, the legislature hears from people and says, you know what, we're doing it. So it winds up in the House budget, not the Senate budget, but it winds up in the conference budget. Now we're back on again. And so it's a little bit of a rodeo, and it's a lot of people that have to say yes to make things happen at the agency level. And usually it's a complicated process, but there is a lot of coordination going on through that whole thing. So it sounds messy, but there is a dance that goes on, and there is communication that goes back and forth, and there is indications of, yeah, we think this is going to happen. And whether it be a reprocurement or a program expansion or a program reduction or whatever it is, it goes through there. And then one other piece is collective bargaining.
Yeah, you answered, that was my question.
Yes. So there is the collective bargaining component as well. And so that gets added in, and how that falls in and what agreement is made between the governor's office and the union and how that gets, the legislature ratifies it, also directs traffic for us. So, I mean, I know that's it's like a deep view into the agency and how we interact with all those entities, but it is the dance we have, and it is the structure under the rules and regulations that have already been established, and it's how we navigate that world.
The other factor that we have here that is completely separate from like the academic conversation of timelines of a procurement is the reality of our IT systems. And there is a concerted effort here at the agency to modernize certain other parts of Pay One and Benefits 24/7 that might make a new portfolio much easier to manage or much harder to manage. So for example, we've been talking about, we've had reports all board season about kind of the syncing of data between Benefits 24/7 and Pay One. And, the manifestation of that is people think they're in one plan, but it doesn't make it over to the carriers because the system data hasn't fully migrated over, and therefore it isn't in the files that get sent to the carriers. We're working on migrating that carrier file production out of Benefits 24/7 so that there is no syncing when it comes from enrollment to actual the enrollment election that an individual makes and that enrollment making it over to the carriers. And ideally, we're on a path to have that completed in, I always have to remember what year it is. It's 2025 right now, for 2027, to have a cut over of that file process at the same time as a launch of a portfolio also injects a lot of risk in what members experience. So that's not I'm not saying that to say that a procurement timeline gets pushed out for that, but there is this fortunate reality that we are working on certain modular enhancements to our system that ideally would predate, and from a timelines perspective, could predate a switchover in the offerings in the portfolio and facilitate that enrollment process so that it is a better experience for all of our members that are electing and the carriers who are receiving that data. So I just wanted to throw out there that there's this piece that's important, that where we are on our IT development also has a direct impact on the experience people would have as the result of a procurement.
Thank you. The more we talk, the more questions I have, but
Uh-huh.
I'll try to refrain from, maybe we can, but I guess, would there be a possibility of a request for new funds this upcoming session, or is that too short of a timeline?
It's not too short of a timeline right now,
You could still ask for.
because we're on the process right now. Just,
So you think it'd be.
it's July 17th. Our new director comes August 18th. So it's 7/17. On 8/18, our new director comes. Decision packages are submitted to OFM sometime in the middle of September. And so there's that space for that conversation to happen here at the agency, and for that to, an outcome of that could be a decision package in the fall that then is the process that Lou was describing. That is certainly within the cards. And like I said, we're clearly hearing from both boards an intense interest in as soon as possible.
Yeah, granted, it's the worst time to ask for money, but thank you for that. My
The
original,
fortunate thing is, Tanya will say this all the time, PEB and SEB money isn't considered GFS. And a lot of the focus of the budget conversations is general fund state expenditures. So there's potentially wiggle room there.
okay. So my original question was to help me manage my expectations, and frankly, all of this has helped that. But to also be able to communicate to employees, because they have asked for this thing, and this is partly why I'm carrying this forward. What impact, and I guess primarily I'd be interested in positive impacts, would a new carrier in the PEB portfolio provide or create to the other providers? I mean, I guess my basic question is, does adding a new one somehow impact rates through competition, through options, more choices? Is there any of that real, or is that just a dream?
I don't think it's a dream. I think there are those dynamics that play out.
Okay.
The more competition there is in a there's a point. It's so some people. I was reminded about this yesterday. Everyone wants more choice, but then there's a point where there's too much choice. It's the same. You could fill that in a lot of ways. My grandfather used to say everything in moderation. There's a point where competition is so great that it also becomes problematic. So there's kind of a sweet spot. If you look at the individual market on the health benefit exchange 1 or 2 years ago, there were over 100 plans, and there was a lot of call for trying to, how does one distinguish between $50 deductible differences and $10 premium differences and all of these things? There's too much choice. Here we're faced the other question that this board has highlighted is it feels like there's too little choice. In SEB, there's a little more choice. Is that, it's the Goldilocks problem. Is that the right amount of choice? So there's a point where yes, there could be, it depends on what networks people would bring to the table. Are there opportunities for additional entrance into our portfolio that might fill out options in more parts of the state so that all the parts that are reliant almost solely on UMP or are solely on UMP have additional access to choices? That could be an outcome, but it also depends on who responds and what they're bringing to the table and what their strategic investments are or plans are for the state. So there's a lot of different factors there. So that's part of why a market check periodically is important.
And I think there's one other factor that's hard to predict is free will. What are people going to do? You add a plan. Health insurance is sticky. How many people are going to move to it? Is it going to be cost effective for the new entity to come in? And that's a tough one. And then are we going to go to a full open, what is the term we use? Active open enrollment, where we're going to ask everybody to reselect their plan. And then there's tons of complicating factors with that because some people won't select their plan and then they'll get defaulted and all that stuff. So, it's build it and they will come is not always true.
And I would just throw into this at this point, speaking pragmatically, hopefully, from a payer perspective, from a vendor perspective, forget about health plans for a moment. If you tell me I'm offering a contract that's worth $1 billion, would you like to bid on it? Of course, I'm going to say yes, right? And then when I understand, okay, but you're going to be one of 27 vendors that we actually give a contract to. So you're actually bidding on 1/27th of $1 billion. How I respond is going to potentially be very different based on what I see and we can debate about, competition is good. You'll be competing with others and that should make you be better and offer a cost-effective price point. But the reality is that, to Dave's point, once you get a large enough pool, it changes what the pool will be willing to do and respond with, right? So I think there is that sweet spot that we have to figure out collectively. And that's part of what needs to be considered and evaluated as part of the RFP. And, this is a good conversation. We've gotten through much of what was in this presentation, so I don't know that we need to belabor what's on the slides coming up. We'll hit a couple of really quick points if that's all right with everyone. And then I'll give you my summary.
But Elliot,
Yeah,
we will
Elliot.
get back to you, John, on slide whatever we're on. But Elliot, and then I've lost track. I think Harry, you might have your hand up with a question. So Elliot and then Harry.
Yep.
For the record, that would be 37 million apiece.
Yeah. 1 billion divided by 27.
Thank you, Lou.
Okay, looking at page 4, which is what I believe that is, when you say negotiate contracts, do you mean negotiations with the bidder?
Yes.
Or, okay.
Yeah.
Where do the unions come into this? When do they negotiate? I don't see any reference to that.
So
Well,
go ahead, Kurt. You can.
I'm just gonna say, I mean, I'm not sure what Lou was referring to because we don't bargain over plans. We only bargain the dollar amount extended what the law requires. And so it's very limited in scope what the union gets to bargain over. Plans isn't one of them.
So I'll give an example. Like when the sub program was launching, to negotiate over a dollar amount, you have to know something about the portfolio and what the general dynamics are of the portfolio and how an RFP can influence the choices that are available could be a factor in what is thought about as what that dollar amount is. So, because in SEB, the SEB board authorized the suite of uniform medical plans like 2 weeks before collective bargaining, the first collective bargaining session with the SEB unions began. And without some sort of benchmark to negotiate from, it would have been really hard to negotiate a dollar amount. So if we're sitting and talking about what a future portfolio here, I could see there certainly be questions at the bargaining table. And the next bargaining session, bargaining happens in even summer years, is next summer. And so I could see if there were an RFP out on the streets, I would anticipate there would be questions at the bargaining table about the potential implications as the union's interest would be to protect members from unintended outcomes. And so I think that's what Lou was kind of referring to, not negotiating a plan design within the fully insured portfolio, but the impacts on the finances of the program by having a procurement. Harry?
Yeah, thanks. I'm just going to try to make a last comment and be quiet. I think that 2028 is absolutely the best case scenario today. I wouldn't say that come January. So having said that, I'm just going to urge PEB. Lou is the COO of the agency. Mary Ann is the acting agency director, to get this ball rolling now and not wait. I know it's only a month, but the new director is going to have a lot to get on board with and may want to think about this for some time or get more information, or it's not on the high priority because, I mean, let's face it, Medicaid is a little bit bigger, et cetera. And so if it is feasible, and I'm not looking for an answer, I'm just saying if it's a way to get this started now so that it's actually moving, then I would urge that we try to do that. Thanks again for listening.
All right, John, back to you. What slide do you want to go to?
So I think the slide I want to go to is the wrap up, but if we go into let me just make a couple of key points in the negotiation process. As with any negotiation, there are going to be things that can be negotiated and can't be negotiated. That's an HCA decision about what portions of the contract get negotiated. And for a medical plan, those can be hundreds of pages long. So it's not a simple, we agreed to do this, you agreed to do that, and we're good to go. And there will be significant red lines typically and changes that are discussed. So all of that process takes some amount of time to make sure that it's clear to both parties who's agreeing to do what and when. And then finally, I really want to call out in the open enrollment, there's a fair amount of work that has to be done ensuring that data transfers happen correctly between us and that plan, so that enrollment is correct, so that billing for premiums is correct, and that to the greatest extent possible, we minimize and mitigate any member experience challenges. So if we jump to the next to the last slide, which is this same slide. I don't recall the number.
22?
That right there. What slide are we on? 19.
Yeah.
Just to again, re-level set. Those are the main components that we're working on. Typically takes 2 to 3 years. And then I'm going to come back to why can't it be shorter? Although we've discussed that in detail. We go to the next slide about risk mitigation or best practices. In my mind, and I believe most folks at HCA's minds, there are 3 real main goals of the RFP process, right? And you can argue that there are tertiary and secondary ones, but one is to make sure that we make the best decision out of the potential bidders, that we choose the best solution for the members. And that gives to the second, which is we'll give the best member experience, both from the implementation and from the ongoing interactions with the plan. And then finally, it's risk mitigation, right? You can say that some of that is for the member experience. We want to mitigate risk for implementation concerns for members, but there's also a legal risk mitigation perspective that we chose the best plan that was available out of the responses, and the RFP was scored fairly, et cetera, et cetera, et cetera. So those, in my mind, are the 3 overarching goals for this. So the question then that we'll come back to is, can you do it faster than 2 to 3 years? There are a variety of pieces that Dave and Lou have already, articulated that lead to 2028 may be the best, soonest opportunity. My answer anytime someone would ask me something like that is, sure, I can do it faster, but you're accepting significantly more risk. The shorter the time period is we try to compress this into, the greater the risks for those file transfers not occurring correctly, for premiums not being billed correctly, for a miscommunication of what the intent was between the parties.
For a mistake in the procurement process that results in a successful protest that reboots the entire timeline.
Yep. So, I don't want to pretend to be Pollyanna, and I also don't want to say, it can't be done any sooner than that, because the reality is it's all about what level of risk are we willing to accept collectively. And that's something that we'll continue interacting with you on. But as Dave said, we clearly get the message. This is important, and we'll start our internal work. Yeah.
So
Kayla.
just one thing I wanted to make sure I understand, and I'm gonna put this at a high level and like genericize it, so it's might not be all encompassing, but so there are things that we can't necessarily make it faster, but there are things that we could think about as levers to keep it from going slower. And the way that I understood what Lou said is, HCA is an influencer in making sure that this is important, but knowing kind of the other, like I hear the governor's office and the legislature are also kind of key entities that will determine whether this keeps moving forward or whether we hit roadblocks and slow down. So if, as we are urging the board to move forward and we have other access to influence in other ways, those are kind of 2 other levers that we could make sure that people are clear that this is what we want. Is that accurate?
And yes, and the agency will be able to articulate the nature of the conversations at both boards. Realistically, probably people aren't going to go back and listen to the audio file, what's going on, but we can say, and it's there. If you want to go listen to it, here's the timestamps. But we can say and talk about the importance of this and the nature of the conversation that happened at both PEB and SEB. And we can, as an agency, we will, convey that as part of the conversations that we have on this topic.
And again, much of what's already been discussed is in those existing slides. And there's one slide in the appendix that puts that big bubble chart into a narrative. What are the key components in each of the phases? Feel free to look through that. You can read them faster than I can read them to you. And don't hesitate to reach out to me if you have clarifying questions or concerns as you do that, or reach out to Dave as well. I'm sure he'd be welcome to call. But whatever we can do to help with that, would love to engage with you. So.
Can we just go back and put slide 19 up on? I was just flipping through and there's one part that I think in all the conversation that we had while we were sitting on slide 5 really didn't come up much that I just want to draw a little attention to, and that's the purple evaluation process. We benchmark that in the slides as something that can happen over a 3 to 6 month period. Some of that is really dependent on how many bidders respond to the RFP. There's a difference in scoring 4 bidder responses and 10 bidder responses. When we did the procurement for the TPA for the Uniform Medical Plan 6-7 years ago, literally the responses were delivered on pallets.
Wow.
We were asking.
That was
for-
an unusual
We were
phone
asking for
call.
10 or 12
Yeah.
copies, but we were getting 10 inches of binders, and we had space, as college professor, 12-inch, 12-point font, single space, page means front and back, or it only means front, and margins can't be greater than this. And you get down to that level in an RFP to be very clear. And we're not going to score pages that are after the page limits, but even with that, it was like 10 inches for a single response.
Facilities called and said, hey, we had some pallets of binders show up. What do you want us to do with them? And we're like, what are you talking about? And then we found out they were for the program, and we're like, oh my, that's a lot.
So that evaluation process, the amount of time that it takes really can be fungible or is influenced by the nature of the responses. But then also, this is the really important part. Just because you are announced as an ASB, again, apparently successful bidder, does not mean that you are guaranteed a contract. And there are many examples in this agency and even this program's history of multiple ASBs announced and then less than the total number of ASBs results in a contract. There are a variety of reasons that a contract might not be ultimately executed. There could be, John highlighted it during negotiation process, there's provisions that the agency will be like, we're not negotiating on that. That's a hard line. Is that a take it or leave it for you? If it is, then no contract's going to be signed. The other side, the other party will have pieces that they really won't agree to, or they won't, that can break down. And there's a point where either side can go, this isn't going to work out. There's no way we're going to get to yes. And that falls by the wayside. The Uniform Medical Plan Plus a decade ago, we had 3 ASBs, 2 contracts, 2 plans that went forward ultimately this last decade. The PEBB portfolio that launched for 2020, we announced 7 ASBs and we ultimately had 4 contracts. So the important part being, just because someone is announced as an ASB doesn't mean that they get a contract. And some procurements lend themselves to a single ASB, and other procurements, it can be multiple ASBs. An example of a single ASB is like our FSA decap vendor. We wanted one single entity to do the administration of those tax preferred accounts. So we had a single ASB announced. And in procurements, if you announce an ASB and you ultimately are not successful, you can go to the next. You can announce a new ASB, and after you suspend negotiations with the first apparently successful bidder. In the context of a medical plan procurement, we end up if we use PEBB as an example, we announced multiple ASBs. We had 7 negotiations going on simultaneously, landed on 4 contracts, and launched. And so that's just the nature of it. So, but I did want to describe the difference and the importance of that apparently word. Is there anything else that we think is high level that might be?
You hit the last 2 that it was to Lou's point. ASB doesn't mean you get a contract, you get the right to negotiate a contract, right? Whether it's successful or not is something totally different. And to Dave's point, can be multiple ASBs, often are, especially with something like a medical plan. It doesn't have to be just one. It's not Highlander. So yeah.
Maybe the one other part that as I was just flipping through, is in the orange section, negotiations. Something else that's really important that happens during negotiations is IT security review for viability of being able to sign contracts. And security standards change all the time. So even with existing partners, we still have to do security re-reviews and make data sharing agreements. So data sharing agreements, along with the main contract and security reviews, are all things that lead to viability to being able to sign a contract. So that's another important aspect here. And you can't shortchange the security review process, even if it's an existing partner that you're under contract with. So I think that's all I wanted to add in from highlights.
And those don't have to necessarily be sequential.
Nope,
We often, even though we're not supposed to be working on a contract until it's signed, that review for IT security often runs concurrently so that it's not a significant delay after the contract is executed. Yeah, great call out.
Kurt.
I just want to say thank you to John and
Yeah.
you and Lou too for the detailed slides and explanation. I feel like I've been through a training now, so I know how to do an RFP.
I've always
I
wondered.
thought you were going to say train wreck. What is he saying?
I'll sign off on your CE credits. Happily.
I've always wondered about this, even though I've been on the board for years, and thanks for filling in that big gap for me.
Thank you. Appreciate it. Reach out if you have any questions, please.
Thank you, John. All right, Dave, you got our 2026 schedule. It's behind tab number 7.
Yes, Chair McDermott, it's still morning. This is the same exact schedule that was presented last week as a draft. I believe it is already filed because the stamp is right there on the bottom right. So this has been filed with the code revisor's office. That means you can officially put all of this on your calendars. And I believe, if I remember correctly, it's 9 a.m. and all of these dates are Thursdays. As we get later into the board season next year, we'll know how many of those July meetings are necessary. For now, I can tell you can remove your board meetings for the next 2 weeks. This is the last board meeting of the 2025 board season. Again, we overschedule, given the complex nature of what the conversation that just happened, we may need more of those July meetings, depending on how the world pans out over the next 6 to 9 months between the next legislative session and also whatever happens with the federal government. So just a reminder that please mark your calendars for these dates. I'll also reach out to various board members since this is the last meeting. There'll be, talk about the appointment process and reappointment process. I usually engage with the governor's office on that in the fall, in the September, October area. So reach out to you about that if you're in a term that is currently set to end this fall, and we'll talk through that whole process. So I'll be in touch in the fall about that. And then with that, I think I turn it back unless there's any other questions.
All right. Any questions for Dave? All right, we're going to go to public comment. So if folks, Harry?
Yeah, Lou, this is probably, I just want to get this in so I don't get cut off at the end. And that's, I wish I was there because I would like to thank the entire staff of the health of the PEB, but most importantly today, the administrative support staff. Jessica and her team have just been incredibly supportive of me, and I'm sure the rest of the board. So I wanted to get that in so that we didn't get to the end and I wasn't able to get in. Thank you.
Well, it's very kind, and we all do appreciate all the work that goes into making these board meetings happen. So public comment, we're going to go ahead and take names. If put your Zoom hand up, we will take names. And again, we'll be able to control your audio. We'll be able to control your ability to turn on audio and video. We can't turn it on for you, but you can control on your audio and video to make your comments. So let's see what we have here. Is that Annette Barca?
Yeah.
Annette Barca? Let's go ahead and make her. Okay.
Wait a minute. Okay, Mike.
Oh, there we go. We hear you.
Okay. My name is Annette Borka. I'm from I live on Whidbey Island. I am a Shiva volunteer and about a 20-year PEB retiree member. I have several things I want to comment on. I'm hopeful, as you said, that during the open enrollment period that you do in fact have longer hours to assist various members. Last year, I heard from a number of clients a great deal of frustration of trying to reach and talk to somebody at PEBB because they had questions. It may have been specifics on a plan. It may be problems with 24/7, whatever. But I really would recommend that seriously look at having at least some people available, maybe to 8, 9 o'clock at night. A second area I have concern is I like the idea that you're making more and more things available on the virtual basis, but that you need to realize that that is an issue, and it's an issue here on Whidbey Island, many parts of Whidbey Island, as other parts of the state, particularly Eastern Washington. And that is because the available internet service that's there is either very expensive or oftentimes erratic. Here where I'm on Whidbey, it is somewhat erratic at times. And it is, for many people, too pricey for them to use unless they go to a local library. And oftentimes they don't want to deal with insurance at the library because they feel personal information may be made available that The last thing I want to comment is a concern on the benefit fairs. I've been to them in the past and I often find them very beneficial. But again, I look at the list and there are none in Western Washington north of Seattle. And while I've not gone to the ones at the University of Washington, I have colleagues that have. And they really feel the University of Washington ones are focused on current employees and not retirees. So those are my concerns. Thank you for making these meetings available. I find them very informative and for the work that you do in terms of making the plans available to us and the rates available to us. Although I don't like some of the rates because they're really high and expensive for people who have separated and or retired. But the work that you put into, I thank the board and the staff members for all the hours of work that they put in. Thank you and have a great day.
Thank you very much. Appreciate your comments. Do we have others?
Chairman Gruber, I want to add two things, just as a quick reassurances to the board. As we continue to expand the availability of content virtually, that is not going to be at the expense of paper options. I will continue to reassure people that we will continue to have materials that are available via print. We know that that's an important piece, and the addition of virtual options is not coming with the subtraction of physical options. And the second is, and I'm pretty sure I know exactly why this happened. Annette just had highlighted that there weren't benefit fairs north of Seattle. Our original publication of slides had truncated the number of benefits fairs on slide 7 of Alyssa's materials and had cut off the last 2 or 3, and those happened to be the ones that are north of Seattle. And so we had refreshed the materials sometime, I think Monday night, and made a little note that they were revised. But I did want to reassure the board that we do have they're just a little later, and that's where they were in the cutoff in Linwood and one up in Bellingham. So there are a few that are north of Seattle, and I think it was an unfortunate feature of the materials being published, and then we noticed that there were some that were left off the slide, and those all happen to be the ones north of Seattle. So we do have some that are north of Seattle, and we've replaced the materials online that have that. We've also been working on the communications for open enrollment, and they do list all of the benefits fairs. It was just something that they got cropped off on this particular slide in the first iteration that was sent out. So I think that just wanted to clarify that part, and I think that's exactly why that happened for Annette's comments. But there are 2 that are north of Seattle.
Any other public comment?
Aruna?
Aruna?
Can you hear me?
We can hear you now, yes.
Thank you very much for informative presentation and including us to be part of the PEB board meetings. My comment is regarding benefit fairs. Often United Healthcare has a lot of presentations that is available virtually, etc. But we don't have as much information from Premera that provides Part G plans, which work as Medigap supplement plan, to supplement the original Medicare. Is there any possibility of having more information about Premera plan?
Aruna, I'll work with the benefits fair team to understand exactly what expectation has been set out, but take your feedback that you're not seeing the level of information available for the Premera Medigap plans as you are other plans, and that requested, so we can see what content is already in the pipeline. I believe we've had some of that feedback in the past, and have been working on some of that. So I know that is, and Alyssa just added that is feedback that we've been working on. So while I can't sit here and commit exactly what I know is going to happen in October or November, it is something that is on our radar, acknowledging that feedback is part of what we've received since last open enrollment, and appreciate you bringing it up again today so that is continues to be on the work stream as Alyssa and her team officially pivot to open enrollment after this meeting.
And secondly, my question, this is Aruna also. My question was around Medicare Part G with Primera, leveling the playing, field in the sense that the benefits to YMCA membership are such because it is always, helpful to have that coverage because that way people are part of the community. There is a socio-emotional needs are met because of the classes attendance as well as being regular so that it is preventing the health issues that one may face. So is there any plans or has there been any plan to include YMCA also coverage part of Plan G? Thank you.
Aruna, I can provide some insights on that one right now too. The structure of the Medigap plans is such that the benefit design is really standardized and set at the national level. And so there is not a lot of discretion for additional pieces of coverage to be inserted into Medigap plans. The concept of those letter plans, if you will, because we're talking about the letter G, is that a G means the same thing wherever you are. And so there is not much discretion to be able to make adjustments like adding hearing aids or adding gym memberships or including vision coverage within them. Those are three questions that we get asked on a regular basis about can those be added in G? And the unfortunate piece is that that benefit design is really federally regulated so that it is uniform across the country. So that isn't something that is able to be changed in benefit design for the Medigap plans. But that is also why there are those other options that are in the portfolio for Medicare retirees to be able to purchase. I mean, you have to be in a different plan. It can't be it wouldn't be a Medigap plan, but there are at least options to be able to incorporate vision, gym memberships, and hearing instruments. Those are a couple of the classic ones that we get asked about with Medigap plans. Of course, it comes with a different premium and a different plan structure, but unfortunately, there isn't really a way to change Plan G because, again, it's federally regulated benefit design. I see you might have a
You are
follow-up
very
still.
right, Dave. Excuse me. You are very right that it is nationally controlled, but our Primera Plan G in some parts of Washington has included YMCA, whereas in Eastern Washington, YMCA is not included, the membership.
I will have some teams follow up on that. Thank you for the information.
Thank you very much.
Any others from the public? Going once, twice? All right, thank you. Our next, this is our last board meeting of the season. Our next meeting is going to be our board retreat, January 9th, 2026, starting at 9 a.m. January 29th, did I say? January 29th, 2026, starting at 9 a.m. with the same format of attendance in person or via Zoom. Dave, any final comments before we end the meeting?
Things that we know. It's hard to predict next week or tomorrow, but 6 months from now, I know what the following we'll be talking about. We'll talk about the results of open enrollment that will have happened. The governor will have proposed a supplemental budget. And in fact, the legislature will be in town and there will be hundreds of bills that are being discussed. So Kane will be back to talk about the current status of bills at that point. We'll also, I'm anticipating we'll have more insights to be able to share about federal legislation that passed earlier this month, any federal legislation that passes between now and the retreat, rulemaking activities, and other information that comes from the federal government just to share with you the impacts. Like I said earlier today, we kind of found within the last week that decap increase. I'm sure there are more things that we'll learn as we have more time with actions by the federal government. And so we'll share what insights we have on that point. And then I think it's very clear from today's questions and conversation that we'll have an update on procurement processes with the agencies and wherever that is. If it's not already apparent from the legislative and budget process that will have already commenced. So make sure that that's on the radar to be able to talk about whatever has happened in the next 6 months on that front. So just want to thank everybody. I'm sure there'll be other things, but that's all that's in my crystal ball today for January.
Yeah, David, I just want to thank you, your team, the board, especially for all the work this season. There is a lot of ups and downs during a board season, and I appreciate you being along the ride with us. And congratulations on we've got a plan year. We've got things that are going to happen in January. People are going to have benefits. So thank you so much. We will see you all very soon. I hope the rest of your summer is awesome. Take care.